Well, good morning, everybody. My name is Jamie McDaniel, and I work for the Association of American Indian Physicians, and I'm so very thankful that all of you could join us this morning. Just a little bit of housekeeping. If you are interested in using the Wi-Fi here at the hotel, you want to either select the H Honors option or the AT&T option, and you'll select that you have a promo or a coupon code, and that code is going to be capital AAIP. So, to get us started this morning are two ladies that I have become very familiar with over the years, Miss Sylvia Rodriguez and Miss Rose Vasquez. They were actually one of our recipients of some funding through Million Hearts, which is making this event possible today. And they were one of two urban sites that looked at process improvements for addressing hypertension. So they will share some of that information with you today. But a little bit about them. So Sylvia is Muskogee Creek and Lakota Sioux. She began at the Urban Intertribal Center of Texas as a front desk clerk 5 years ago. Sylvia quickly realized how much she enjoyed helping her UITCT community members, so she looked for more ways to help, which led to opportunities to really get involved. In a matter of months, she studied and received her certification as a community health worker and began working with diabetic patients. Sylvia didn't stop there. It was time to incorporate her love for the outdoors and keeping physically active by becoming a volunteer in the garden. For Sylvia, being in the garden was yet another way to help the Dallas Native community. Most recently, Sylvia has become a Dallas County Master Gardener and also received her personal training certification through the Native American Fitness Council. She has a positive attitude and is passionate about helping educate the Native American community on health, fitness through community and outreach programs. For Rose, she's been with UITCT for 3 years. She is a registered nurse in the state of Texas and is currently working on obtaining her Certified Diabetes Educator certification. She works directly with the diabetic patients in completing their foot and eye exams. What she enjoys about her role is being able to establish relationships with the patients. She feels that securing this is important in being influential in their health. Please help me welcome Sylvia and Rose this morning.
Good morning, everyone. So I'm Rose, and this is Sylvia. We're a little bit nervous, so just bear with us for a little while. Okay, so we are from the Urban Intertribal Center of Texas, and we're going to start off with just kind of going over what we do in Dallas and a brief description of our services. Okay, so we are a nonprofit organization. We community-based service. We have community-based services to meet the diverse needs of American Indians, Alaska Natives, and we serve American Indians who are members of federally recognized tribes. So currently there are over 62,000 members residing in the Dallas-Fort Worth Metroplex. Right now, our clinic has an active user population of about 4,600 patients, and we've had a total of about 22,000 visits just in the past 12 months. And these are what we basically provide at our clinic. So we have our primary care clinic, a small dental clinic, pharmacy, our diabetes program. We also offer behavioral health counseling and women's and children's services. A part of that is we have somebody that comes out for WIC, which offers our prenatal and pregnant ladies some services for them too. We also have an immunizations program, our community garden, of course. We have an employment and training center. They have resources for people that are looking for jobs, recent high school graduates, and also anybody that's looking to, further their education. And our outreach center. Okay, so to get started on our actual Million Hearts program at the UITCT. So this is how we started pretty much. We launched the Hypertension Control Change package to provide healthcare practices with a menu of evidence-based practices to improve hypertension control. So we started out by recruiting 60 current patients at our clinic that had uncontrolled hypertension. We offered a group setting where we kind of educated them, went over what we were going to do, what our goals were for the program. We provided them with blood pressure monitors and some self-management tools that we'll go over here in a little bit too. So the patients were asked to record 2 readings per day, at least 3 days a week. And they were to communicate those readings every 2 weeks to the Million Hearts hotline. And I'll let Sylvia start over this section of it.
Good morning. Okay, so for our patients, we made up a package, a support package for them. We gathered it all and we put it in a backpack for them, and we also provided a lunch bag for them. And so what I did is I went through each item with them and showed them how to use it. So the first item that we gave out was it was a pedometer. I took it out. I showed them how to get it started. I showed them the best way to get their steps in would be through putting it on their waist as opposed to carrying it around their neck. And we also provided this journal. It's for not only recording your exercise, but what you eat, how you felt at that time before you ate, if you were really hungry, if you were just a little hungry. It also helped you keep up with how much water you took in. And we also had them record their blood pressure at that time on the pages. So it's a really good book, and I'll pass it around if anybody's interested in looking at it. They really enjoyed this. The other item that was in their support package is a stress management book. And so I went through each page with them and explained to them the different ways that they could manage their stress. And some of the things in here were stretches, which I went over with them. It's really good. We do this, well, I do at work because I sit behind the computer all day, sometimes, unless I'm out in the garden. That's a good stress reliever. Also, talking to another person about what you're stressed about was also one of the tips. Going walking. This self-massage was really good, and I went through with them on that as well. So I enjoyed going through that with them. Another one is the DASH cookbook. I went through with them, and they were really excited to use all these items. Another one was, along with the stress management, we also had those little squeezies. We don't have any right now, but like that. We have a few that were some new ones I thought were really cute. You squeeze them and their eyes pop out. So those were some of the things that we had, and of course also the blood pressure monitors were in there as well. So with that, okay, so also we have a folder with education materials and the blood pressure log. So I made up a folder for everybody, and inside is information on hypertension, what it is, who it affects, a blood pressure log, which we have in there. Excuse me. We also included information on lowering your blood pressure through DASH. It's just a few pages. And one of the things that I really liked was a shopping list that we provided with them with low sodium foods. And then controlling your blood pressure. And then on the back, it gives you a chart so you can kind of gauge if your blood pressure is within the normal range or if it's getting too high. All this is really good information. They all really appreciated it, and I enjoyed putting it together for them and explaining it to them. Rose is next.
Okay, so this chart basically shows where we started off at as far as blood pressure control with our patients. So it did. It was nice to see that it did actually go down. So we started about 62%, and we ended up about 57% within a year. So what we gained from this, some of the pros were, the lifestyle changes were addressed during group education. We focused on making it more of a lifestyle habit change rather than just a temporary or like a fat diet or something like that. We also made it a goal to have any medication adjustments done, and of course quickly, so that we can offer the fastest solution or help. The wellness journals helped increase awareness of the connection between high readings and pain levels. So that's one of the things that Sylvia went over, was their wellness journals. We also had a lot of family involvement and saw that it created a support system for the patients. These are things that they verbally reported to us. Patients became more aware of their eating habits and how exercise helped to control their blood pressure. So the pedometer was handy in that. That was our way of kind of involving exercise into the whole blood pressure control. Some of the cons. At first, the blood pressures that we handed out were loans. We were doing just like a 3-month loan just for the start of the program. So one of the cons was that the patients wanted to keep their monitor and not have to turn it in. Frequency of readings were difficult to maintain. Patients preferred meal substitutes instead of the DASH diet cookbook. Patients not needing any medication adjustments felt that they were not getting feedback on their blood pressure readings. And that basically means that the people that were calling in their blood pressure readings that didn't need any changes or anything just felt like they weren't hearing back from us to let them know everything was okay, or just to keep everything the same. Some of our concerns, the dedicated phone line for receiving blood pressure readings. We felt that we needed just a person just to dedicate their time in answering the messages and calling people back. Sylvia was in charge of doing that, and that's, along with her other clinical duties that she had at the center. Our community healthcare worker input readings into the chart, provider time, medical assistance times, and the medication changes. So again, a lot of it was, we could have really used a person just dedicated to do all of these things. So at the end of our program, these are a few of the people that we got to take a picture of, but we had a small ceremony for them, handed them certificates, and once they completed their 3-month trial. We also were able to get a grant extension. So every hypertensive patient receives a blood pressure monitor so that they can track their readings at home. So far, there have been about 500 monitors handed out. So these are now monitors that they could keep. They no longer have to turn them back in or anything. They got to keep these. Thanks to the extra funding, the participants were able to keep their monitors. Education is provided to teach patients how to properly use the monitor, and we also learned that follow-up is essential. So we showed them a YouTube video. The education was done in the room while they're there visiting or having their medical appointments done. And at that point, we decide whether or not they are good candidates for the blood pressure monitor. And I'll let Sylvia talk about our awards.
So it's basically self-explanatory. We went to the Areas Director Awards, and our group for the Billion Hearts won. And so this is everybody that was included that got together for our group, and that was a really nice surprise. So that's all I have to say about that.
Okay, in conclusion, the most important lesson that was learned was how important it is to keep their blood pressure under control through the different lifestyle changes and awareness. The patients are excited to receive the monitor and are more aware of their readings tend to run higher than normal. We feel that handing out these tools gives patients a sense of self-empowerment. Overall, our goal as medical providers is to see a decrease in hypertension and an increase in healthy hearts. And that is it. Thank you. And we want to thank Jamie for inviting us out and for everything she's done for our center and for helping us putting this together. Thank you.
Thank you, Jamie.
So what they failed to ask was, does anybody have any questions for them about their process or what happened? So the question from the front was if they were required to submit any data as part of this funding.
Yes, we submitted monthly reports on what our blood pressure numbers were for our clinic.
And
Oh,
how it
like
was
aggregate numbers for
Yes,
the.
and we used our GAPRA numbers for that too, GAPRA measures.
Okay. Well, I'd like just to echo what she said, I really want to commend the work that you're doing. So, if there's any way that AHA can support in the future, we're happy to do that. Just, reach out to Jamie and I'll have some cards here too.
Okay.
For you guys to get. We do have some dollars for some of the programming that we're doing in the clinical setting as well, that could,
Okay.
might leverage.
Okay, thank you.
Anybody else? Oh, we've got one.
So as far as the support, like the pedometer, the materials, I went over all of it with them, but the MAs went over how to use the blood pressure cuff with them. They just went over the blood pressure cuff and taught them how to record their readings and how they're supposed to sit, when you get ready to take your blood pressure. But as far as the other stuff, I went over all of it with them. Yes, we had, the way it was set up is we had groups of, I believe it was 6 or 8 people come in on certain days. And so we took time out, I think it was 2 hours? 2 hours. And we went over a short video with them, a little PowerPoint, I guess. And then we went over the whole program with them. We explained it to them. So it took about a couple hours, but we did it within, I think we had like 6 or 8 groups, I don't remember, come within 2 weeks.
I want to add also that what we're doing now, since we are still handing out the cuffs, we address them while they're visiting the provider. So for their medical appointments, pretty much, if their blood pressure during triage is high, we kind of look over the patterns of their recent visits. If they've been remaining high, it makes them a good candidate to get a blood pressure a cuff if they don't already have one. So at that point, the provider will, while they're in the room with them, they'll go over what we're handing out to them. The MAs will go over the video of how to properly put on the monitor.
All right, well, thank you.
Thank you.
So one thing that I want to reiterate about their program is that it was really all-inclusive. So everybody from their clinic administrators to their providers to their MAs, the nurses, everybody was involved with this process. So it wasn't something that their leadership decided to do and then it kind of trickled down to the people actually doing the work. It actually took the involvement of those different levels to put this together and for everybody to really agree on how that was going to flow for their particular site. So that was a really big factor in how this program was implemented. Yes. Let's see. All right. So up next, we are going to have, excuse me, Commander Manon Tillman and Hazel James, who are going to speak from the Pawnee Indian Health Center. So I'm going to get the presentation up and running. All right. So Commander Tillman is the Chief Nurse Executive for the Pawnee Health Center. She is a member of the Osage tribe and has been a registered nurse for 36 years. She received her nursing degree from Oklahoma University and her master's in healthcare administration from Oklahoma State University. She spent 21 years in the private sector working in hospital, ambulatory infusion, and home health settings before entering Indian Health Services in 2004. Her Indian health experiences have been as a quality improvement program manager, accreditation specialist, compliance and credentialing officer for the Pawnee Service Unit, Southeast Region nurse recruiter for the Oklahoma, Albuquerque, and Nashville areas of IHS, director of nursing at the Oklahoma City Urban Clinic, and recently spent 3 years as the division leader for the Osage Nation health and wellness programs. She was directly involved in assisting the Osage Nation to enter into 638 self-governance of the Pawhuska Health Clinic in 2015. She has 2 grown children and enjoys spending time golfing, sewing, and attending concerts with her husband Chuck of 34 years. Hazel is the clinical nurse supervisor with Pawnee Indian Health Center and Indian Health Service Clinic in Pawnee, Oklahoma. Ms. James has been the clinical nurse supervisor since 2004. If you all will please join me in welcoming Commander Tillman and Ms. James. You can use the laptop, or we have, she's gonna go first. Okay. We have a clicker, or you can push the right arrow on the laptop,
Okay, I probably wanted,
whichever is most comfortable.
I think this is gonna be most comfortable for me. Good morning. Oh, that's loud. Good morning. Our story goes back probably, I guess, since about 2010, whenever we began to look at strategies to manage blood pressure. We are an ambulatory care clinic, and we have several services, pharmacy and nutrition, optometry, dietitian. And so we had all this group to work with us. And one of the things we decided is, well, we needed to find out what we were measuring. And a strategy we decided was, we needed to know the definition of a strategy. And it's a careful plan or a method for achieving a particular goal over a long period of time or to achieve a goal. And that year in 2010, our GIPRA goal was 40%. And then as we looked at our report said we were running like about 15.6%. And 40% is not a bad goal, but 15%, you've got a ways to go. So we began our plan of action and decided we were wanting to meet that goal of 40%. So in September of 2010, we realized that our goal was 40%, and that we needed to develop a plan to for achieving our goal of 40%. So one of the things we included in our plan of action was we needed to define our GIPRA measures, and then GIPRA, for those that may not be familiar, is the Government Performance Reporting Act. And then we wanted to gather our committee group, along with our GIPRA group, and try to come up with some brainstorming ideas where that we could be able to achieve this goal that we were working toward, and develop some strategies that we could implement a plan or a method in order to get this accomplished. And then we wanted to look at some problems, or what we thought was problems, and maybe some solutions that would help us to achieve our goal. And then lastly, after we would get our everything completed, we wanted to go back and look at our lessons learned. So one of the first things we wanted to do was to define what we had to measure. And so we looked at our definition of our blood pressure. And one of the things we kind of honed in on was we were looking at a total diabetic population. And it had to be within the reporting period, and they had to have at least 2 visits within the past year. And they had to be 2 diabetic-related visits. And we looked at our numerator. Our numerator was how many patients we had with a blood pressure documented during the reporting period. Our reporting period at that time was June 1st through June 30th. And so that was our reporting period. And then we wanted to look at patients that had a controlled blood pressure that was less than 140/90. Our CRS, our clinical reporting system, uses an average of the last 3 blood pressures documented on a non-ER visit during the report period. And if those are not available, we can use the average of the last 2 non-ER blood pressures. If a visit contains more than 1 blood pressure, the lowest blood pressure will be used, defined as having the lowest systolic value. And we go on and we thought we really need to look at blood pressures because we needed to, if we were going to achieve that goal of 40%, we also needed to know what our target for our blood pressures would be. So the average systolic value is calculated by adding the last 3 or 2 in the visit systolic values and dividing those by 3 or 2 if that's all that the measures you've got. And the average diastolic value is calculated by adding the diastolic values from the last 3 or 2. And if the systolic and diastolic values do not meet the criteria for control, then the value is considered not control. Don't ask me to repeat that again. And we also looked at our million hearts during this time too. So we had to look at the definition of a million hearts. And the numerator for that was patients with blood pressures greater than 140/90. And our denominator was a user population, ages 18 through 85, diagnosed with hypertension, and no documented history of end-stage renal disease or a current diagnosis of pregnancy. And during our brainstorming, we looked at a couple of things. One of the things was our diabetics, we told them to fast for their lab work, and they were instructed to not take any medicines. And then we discovered not all staff knew how to take a manual blood pressure because we were so dependent on the electronic machines that, a lot of them was using the same type cuffs and not measuring, and so we weren't getting an accurate reading. And so we decided we were going to make a change and go with a manual blood pressure rather than the electronic. A competency was developed using the American Heart Guidelines on the blood pressure guidelines. And we use that competency to focus on how to determine the correct cuff size and what is uncontrolled blood pressure. Our staff took advantage of every diabetic visit we had and educated the patient on how to take their blood pressure medicines prior to their diabetic visit. And then the staff also pointed out changes that we'd made in our pre-appointment letters, because earlier I'd said, we were telling patients, not to take any medicines. And so we changed our pre-appointment letters to take their blood pressure medicines and nothing else. I think we were always under the concern that if they took their blood pressure medicines and they might get hypoglycemic and faint, you didn't want all of that going on. So it was better just to say, don't take any medicines. But then when we began to realize that by taking their medicines, it made a big difference in their blood pressure readings. And then I'm going to turn this over to Manon.
I wasn't at Pawnee during this study, but it continues, and the work that they did then still is applicable now. One of the first problem that was identified that was, like she said, as long as the electronic blood pressure machines were available, the nurses were going to use them. So it was just a culture change of getting them used to taking the manual blood pressure reading and learning those cuff sizes. The solution was that they got each one of them one of these little baskets, and they're very possessive of their basket. They have their blood pressure, all their blood pressure cuff sizes in that basket, as well as their thermometer and their pulse oximeter monitor. And they take it with them everywhere to each room. They also encouraged them to screen the patients to the exam rooms. They were screening and then sending them back to the lobby, and then they would have to sit there and wait and then come back to the physician's room. So all that moving around and doing all those things in the anticipation of seeing the doctor, they thought maybe that could also be causing their blood pressures to rise some. So problem 2 was to screen to the room, which created another issue, and maybe some of you all have the same issue. They were unable to share the computer with the provider. The screen was locked many times, and we're still having this issue a little bit today, is that too many people logged on the computer causes the computer to slow down, and then sometimes it just goes off and they have to reboot and it slows everything down. So it just created a bottleneck of getting the patients in, and does still. So to help that, they developed a nurse intake form. So the patient, while they're sitting in the lobby, will fill out this form as much as they can get done. And then when they go into the room to be screened, they just take that information off that form and enter it into the electronic health record. They tried to do a generic login for everyone so that there wouldn't be all this back and forth stuff, but then the Dragon software wouldn't work. And like I said, we continue to work on this issue today. We don't want to use paper because that is our goal, is to become completely electronic, but then sometimes you just have to do what you have to do to get your patients through. We don't want them sitting there waiting, and again, that just increases anxiety and blood pressure readings. The third problem was the patients forgot to take their blood pressure medication, or their blood pressures were too high at the initial reading. And if the visit contained more than one blood pressure, the lowest reading was what we used in the study. So if they took it at the beginning and it was too high, they let them take their medicine, sit, rest, and then go take it again. And if that second reading was okay, then we used that reading. Solution, I just said that. Also, if the blood pressure remained a little elevated, we could send a public health nurse to their home and have them take it in a more relaxed and comfortable environment and see if that made a difference. These are the results of the study. This is for the year 2011. It went from 25.4% to 54.3% with controlled readings. And then over the last few years, all the way up to the end of the GIPR year 2017, and we don't have any data right now for this year, and the GIPR year has changed, so we won't have that available till the end of September. But it has much been sustained around 81 for million hearts, 83, and then 81, and then for the GIPR, it's 87, 89, and then 87%. So it's stayed it's been pretty sustained. So we're really, really proud of that. So we're hoping this year's reading is going to be as high. So the lessons learned were that when you're brainstorming, no idea is too far out there, and that's absolutely true. The most minute thing that you think might not even be a consideration might be the answer. So you want to take and listen to everyone's ideas. And to meet the blood pressure measure, we would have to change our current process, which was to change from the electronic to the manual blood pressure cuffs, and some of the screening processes. And we would need to remove barriers such as the handheld sphygmometers, which everyone now loves, and you probably couldn't get them to go back to the electronic if you wanted to. Others where patients were relaxed at the end of the visit. Their readings were improved because of that. Taking their blood pressure medication improved the readings as well, using the right cuff size, and their appointment letters. And that just goes back to health literacy. You need to make sure when you send somebody a letter that they are able to understand what is in the letter, because so many times we just assume that they know what we know, and they don't. So you need to really, really look at what you write and how you write it, and it needs to be understandable to them. Blood pressures can be recorded at any time in any clinic. Our dental office is very good at getting blood pressures for everyone when they come in there. We're also working on trying to implement possibly doing this in audiology and in optometry. And this is it. We used, I have a note here, let me find it. This was the guideline at the time for the IHS clinical reporting system, but in November of 2017, the American Heart Association definition of a normal blood pressure was defined as 120/80, and currently the GIPR guideline is 140/90. Any questions?
Somebody's got to have one.
What was that?
I said somebody's got to have
Stacy?
one.
So, hello, can you hear me?
There we go.
Okay, hi. So as far as your patient exam rooms and the nurses using the equipment, do all the exam rooms carry, can you hear me still? Okay. Do all the exam rooms still carry manual blood pressure cuffs individually, or?
Well, each person has their own set.
Okay. The rooms, is there a reason why they don't have installed blood pressure cuffs on the wall, the manual ones?
We just don't have those.
We still have blood pressure cuffs on the wall, but we rarely ever use them. We've really become dependent upon those little baskets that they carry around, because you don't have to share that with anybody. It's theirs, and it makes screening quicker because they don't have to wait on anybody.
Okay, sorry. Thank you.
And what they have, I know the ones on the wall when you have to change and get them all. These are so, I don't know what brand it is, but I mean, they just clip on there real fast. So if you need another, what's it called?
Welch Allen. Well, the brand that we use is Welch Allen, and
Welch Allen, okay. Yep, they're really keen.
Any other questions?
Did I understand that in each clinic, they take the blood pressure?
Right now, only in dental. Sometimes physical therapy will, depending on what's going on, but we're looking forward to maybe optometry and audiology doing it, yeah. But there's gonna, of course, need to be some training with their staff to make sure that they're doing it correctly. But that is something being discussed.
Anybody else?
Do you think he'll ever adopt the new guidelines? The new AHA guidelines that came out in the fall, which I know would, hurt a lot of our facilities.
Well, I'm gonna let Tina answer that.
Hi, good morning. I'm the area. I'm not officially part of their group. I'm here for moral support and to answer questions. But I'm with Indian Health Service in the Oklahoma City area, and I'm the GIPR coordinator for our area. And actually, for the blood pressure guidelines, they are not changing. We don't have plans to change them. I don't know exactly what that reasoning is, but I do know that for currently what we're in, they're still going to be at 140. We're looking at trying to maintain control of 140/90. And then in 2019, that year is going to actually start in October 1st of 2018. So as soon as they try to get those things out in advance. And so as far as I know, that has not changed. So that's what we're still sticking with.
All right, well, if there are no further questions, let's give our speakers a round of applause, please. All right, everybody, we are going to get started with our next speaker. I hope you enjoyed your break. So next up, speaking to us today is going to be Summer Smith. She is a licensed therapist and the director of behavioral health at the Oklahoma City Indian Clinic. Summer has worked in the area of behavioral health for 12 years, having served the homeless population, victims of human trafficking, veterans, and currently Native Americans. She practices trauma-informed care and has been using eye movement desensitization and reprocessing therapy since 2013. Summer graduated from the University of Oklahoma with a Bachelor's of Arts in Psychology and a Master's of Social Work. She is a member of the Muskogee Creek Nation. Join me in welcoming Summer.
Good morning, everybody. So I gave all of you, hopefully all of you, a handout for us to follow. I'm not going to use PowerPoint this morning, just our good old-fashioned hard copies. So I'm really happy to be here with you this morning talking about mental health on the last day of Mental Health Month. Like she said, I'm the Director of Behavioral Health at the Oklahoma City Indian Clinic. Is everybody familiar with the Oklahoma City Indian Clinic? Okay, awesome. I think those two are over there. But just to tell you a little bit about our behavioral health department at the clinic, we are a team of 8 licensed full-time therapists. We have one psychiatrist. He's part-time. We keep him very, very busy. And we have one integrated behavioral health consultant, which we have fully integrated into our medical team and are continuing to try to integrate that more. And we'll talk about that this morning. We also have a mentoring program that's basically set up like a Big Brothers Big Sisters program. We have prevention grants for suicide prevention, substance abuse prevention, bullying, and domestic violence prevention. And then everybody in our behavioral health team is trained in eye movement desensitization and reprocessing therapy. So we're all using a trauma-informed approach, and that's the one that we chose really because we've seen so much powerful success with that. How many of you are familiar with EMDR therapy? Just curious. Okay, hardly no one. That's usually the response I get. Okay. I'm here this morning to talk with you about mental health. I know this is a hypertension event, so I want to be the first to tell you I'm certainly not qualified to talk to you specifically about hypertension, but I am qualified to talk with you about mental health and the connection between the two and how we can best work together as multidisciplines to make that connection and to serve our patients who are suffering from hypertension and other health factors. So if you look at the risk factors, of course, for hypertension, what are you seeing? You're seeing obesity, unhealthy diet, inactive lifestyle, alcohol in excess, smoking, chronic toxic stress, unhealthy relationships, right? When I, as a mental health provider, am meeting with someone, the factors that I am seeing are, guess what? Obesity, unhealthy diet, inactive lifestyle, alcohol in excess, smoking, chronic stress. So again, obviously we're seeing a lot of the same things. We're treating them differently. And my hope for the future of treatment in this area is that we can collaborate, use multidisciplinary approaches, use integrated approaches, and understand the connection between those two in a much different way. So I want to direct your attention now to that handout that I gave you. It says the truth about ACEs. This is just a really colorful little depiction of the ACE study. How many of you have heard of the Adverse Childhood Experiences study? Okay, cool. Again, that's usually the response that I get. There's usually a handful of people in the audience who have heard of the ACE study and many people who have not. So I love when I get the opportunity to talk about that study because in my opinion, the ACE study is the most profound public health study in our history. And I know I'm biased as a mental health professional, but it's extremely, extremely important. So just to give you kind of a brief overview of that, the ACE study was done by 2 doctors who basically looked at a series of adverse childhood experiences, a list of 10 things that we can go through in the first 18 years of our life that are traumatic, things like sexual abuse, neglect, parental domestic violence, parental divorce. They look at these, and then what they did was they compared them to health factors, and the findings that they found were incredible. I've kind of become an ACE study nerd, so I'll tell you when I was in San Diego a few years ago for a conference, I actually got to hear from the author of the ACE study, so that was huge to me, and I want to share with you a little bit about the story that he told us because it gave us even more information. So that's Dr. Vincent Folletti, and he told us that basically how this came about was he was doing an obesity clinic. So he was working with patients who suffered from obesity, and he was trying to help them. He had them on a program. And he saw a lot of success with it, but he also saw a lot of dropout, even from people who were actually losing weight, and the program was working for them. And he could not figure out why these people were dropping out. So he said, I wanted more information. So I started questioning the participants to find out what is going on with them. Why, number one, why is obesity such an issue for them? But number two, why are they dropping out even though they're losing weight and even though it's helping? So he started asking them a series of questions about their life and their history and everything that you could think of, right? So he told us he was sitting with a woman one day, and he asked her during his series of questioning, how old were you when you lost your virginity? And he said she kind of stopped for a second and was taken aback, and he thought, okay, wait, I've overstepped. She probably has no idea why I'm asking her this. This is an obesity clinic. Let me rephrase that. How much did you weigh when you lost your virginity? And she said, I weighed 47 pounds. And he said, let me ask you that again. That can't be right. How much did you weigh when you lost your virginity? She said, I weighed 47 pounds because I was a child and I lost my virginity to my father. This was a light bulb moment for Dr. Folletti because what he realized was After that light bulb moment, asking more questions about that, more questions about trauma and childhood, he learned that this is one of the number one problems that he's seeing. This is what's causing the issue here. Now, for this young woman, what she shared later was that her sister, who was overweight, was not being abused by their father. So she wasn't a target because she was overweight. So she learned, if I can become overweight, I will no longer be sexual abused, I will no longer be a target. So weight and obesity was actually the solution for her. It was not the problem. And so that kind of changed the way that he was looking at this. He was looking at obesity in some of these people as the problem, whereas it was actually a solution. And he learned, as he continued to question them about their childhood trauma, that adverse childhood experiences were extremely common. So he and Dr. Robert Anda actually expanded that study, and that's where we get the adverse childhood experiences study. They questioned 17,000 people, and the findings are sort of beautifully laid out for you in this handout here. But the biggest thing, number one, that they learned is that they're extremely common, okay? A high percentage of the people that they saw had experienced at least one ACE, but 1 in 8 had experienced 4 or more adverse childhood experiences. And basically, to put it short, the more adverse childhood experiences a person has, the higher their risk for, guess what? Lack of physical activity, smoking, obesity, diabetes, suicide attempts, depression, STDs, heart disease. All of these health factors go up consistently the higher the ACE score. So, this is why this is an important conversation for us to have, especially as multidisciplinary teams. Everybody, in my opinion, everybody should be aware of what the adverse childhood experience study shows, and we should be talking about it. And we should be talking with our patients about it. So again, just to give you kind of some specifics of the study, what they found for people with a ACE score of 4 or more, so there were 10 areas of adverse childhood experiences. You're rated on a scale of 0 to 10. 0 means, of course, that you've had none on the list, 10 that you've had every one. Also in your packet is a copy of the ACE questionnaire on the back if anybody is curious of what your own ACE score is, or if you want to use this in your practice. So for people with an ACE score of 4 or more, their risk of COPD is 2.5 times higher. Their risk of depression is 4.5 times higher. Hepatitis, 2.5 times. Suicidality, 12 times higher. And for people with an ACE score of 7 or more, they have triple the lifetime risk for lung cancer and 3.5 times the risk for ischemic heart disease. So these are huge, huge numbers, okay? And so a lot of times people will say, well, of course, they have all of those risk factors going up because they've been traumatized, so they're probably drinking more. They're probably smoking more. They're probably participating in unhealthy behaviors. So that's why those risks go up. True, there's absolutely truth to that. But interestingly enough, what the science shows for people is that even those people with higher ACE scores who did not participate in high-risk behaviors, their risk for heart disease, COPD, obesity, and those things also went up. And the biggest reason for that, to tell you in a short presentation, the biggest reason for that is the body's stress response system, the body's fight or flight system. We're all aware of that, right? What happens when you're exposed to toxic stress in childhood or beyond is that your body is going into fight or flight way too often. For some children who are exposed to domestic violence in the home every night, or whose parents are, abusing substances nightly, or who are being sexually abused by a family member every night, those people, their fight or flight response is kicking in every single night. Okay, so if you can imagine the cortisol, the adrenaline, all of that physiological response that happens when you go into fight or flight happening every single night over and over and over, this is absolutely going to affect your health long term. Okay, and to me, if you think about it too, for those of us, many of us working with Indian people, this is one of the best explanations for historical trauma. Because how many of you have had a conversation with someone about historical trauma and they will say to you, yeah, but that was a long time ago, so they should be over that by now. Why are we still seeing issues when that was a long time ago? Well, this is an excellent explanation for that when you hear that question asked of you, because this is what happens, right? These changes in our biology are carried over from generation to generation, particularly exactly because of that. The scientific name for that is the hypothalamic pituitary adrenal axis, but I just like to say the fight or flight system because that's way easier. So, especially if you're trying to have that conversation with somebody who's not in the medical field. So again, these are the things we know about the connection between those health factors, hypertension, COPD, you name it, and trauma or mental health. So the reason that this is important and the reason that I share that with you today is because we can absolutely use this in our practice in a multidisciplinary way. So I know all of our organizations look different. So that's going to look different for everybody. Another thing in your packet here is an ACEs resource packet for health providers. So what can we do as healthcare providers to incorporate ACEs? But I want to share with you some of the things that we're doing. Ideally, if we're dreaming big, I would say that universal screening would be the direction that we should be going, right? Why could we not screen everybody? Why could we not do an ACE questionnaire for everybody that we see and educate them on what that number means for them? That's one thing that we're moving toward at the Oklahoma City Indian Clinic. We started with, we have a publication that goes out quarterly. It's called the Horizons Magazine. And all of our patients, all of our providers, all of our population sees that. And so I put together an article for that magazine that talks about the ACE study and puts it in layman's terms, talks about the ACE study, what might your ACE score be, and then what might that mean for you, but then what can you do about it? So it's like this light bulb can go off for people, like, why, I've been unhealthy and unhappy for so long, and I had no idea why. For some people, this is the answer. Not for everybody. I'm not suggesting that everybody has a high ACE score and this is the answer to all of their problems. But for many people, especially Indian people, we've got some high ACE scores, and they have never even heard of the ACE study. And they have no idea what that ACE score means for them, and they definitely had no idea that it could be contributing to hypertension and heart disease and lung cancer and smoking and everything else that they're dealing with, right? So that was the first step for us, is educating our entire population on the ACE study, the findings, what an ACE score might mean, and what you can do about it. So there's, in that whole article is all of that information. The other thing that we're doing is integrating our mental health into our primary care. So I'm not sure what organizations everybody is from, but is anybody currently doing integrated behavioral health in their practice? You have a behavioral health clinician that you work side by side with, or, okay, awesome. So again, I know that looks different for everybody, but just kind of sharing, one example that's working for us is we do have a licensed mental health provider. She's a licensed licensed professional counselor, and her office is in our medical department. So even though we have this behavioral health department within itself, we have 8 licensed therapists doing psychotherapy all day long. We have another licensed therapist, and her complete job, her full job, is to be embedded in the medical department. And so that's where her office is. She attends the provider meetings. She attends the nurses' huddles when she can. Her whole job is to educate and to be involved. And then the biggest thing is that when a provider sees some of these risk factors, so again, we're educating our providers about the ACE study. We're saying this may be an answer to some of the issues. If you see chronic hypertension, obesity, stress, smoking, STDs, high-risk behavior, consider that we might want to call Amanda, that's our integrated behavioral health consultant, and just ask her to come into your exam room during whatever appointment they're there for, and let her talk with him about this. And let's see if we can dig a little deeper and get to the root of some of these problems, and that way we can have even better success and even better long-term outcomes. So that's what they do. We not only are we having her screen the patients to do their ACE questionnaire and find out what their ACE score is, but we're doing universal screening for depression, issues related to domestic violence, substance abuse, alcohol abuse, and then we ask questions about bullying. So every patient that comes into our clinic, no matter what they're there for, they're going to be given that screen and ask those questions. And so even if they're there for a flu shot, we might discover that they're suffering from depression and that they've thought about suicide in the last month. And then when the provider or the nurse sees that that screening is positive or that there's something concerning on that screen, then they will call our integrated behavioral health consultant and they will say, hey, I've got somebody here that I'd like for you to come talk to. And she will come right into the exam room, excuse me, and she will visit with them about what's going on. Let's do an assessment. She can give them the ACE questionnaire. If you're working with pediatrics, I know if you'll look at this ACE questionnaire, this says the first 18 years of your life. There is actually a modified version that is for younger people. So you can still be looking at their ACE scores and asking them questions about adverse childhood experiences even before they're 18. So that can be done in a pediatric setting as well. And then once that is done, then again, the behavioral health provider can talk with the medical provider, and we can talk about, okay, here's what we think is going on. Here's the big picture that's happening here, and here's how we can, treat those experiences. If you do not have a behavioral health department in your organization, or you don't have the capacity or the means to put an integrated clinician, to take just one clinician to put in there, then I encourage you to partner with trauma-informed providers at other organizations. If you are interested in that, I have an entire list of trauma-informed providers in Oklahoma. I have a list of EMDR providers in Oklahoma. Oklahoma has actually a pretty growing group of eye movement desensitization and reprocessing therapists, which is awesome. And so that's a really good treatment for trauma. And so if you don't have those within your organization, we can certainly link you to those if you think this would be helpful for the population that you're working with. Again, this is, and this is my opinion, but this is what I believe. If we could move in this direction, we could really be connecting mental health and these health factors much better and getting to the root of this. So to give you a case example of that, just kind of in action. We had a patient in our clinic a few weeks ago who came to the medical clinic for high blood pressure, chronic stress, declining health, weight loss. He just felt overall unhealthy and keyed up a lot of the time. So certainly his blood pressure was going up and his health was going down. And he had recently come out of the hospital because he had suffered a heart attack. And so he was coming in with these health issues, but he screened positive on his depression screening. So they called our integrated behavioral health consultant, who actually happened to be out that day. So I think it was me that went in. And so I'm visiting with him, and he says, ever since I had this heart attack, I just am in this constant state of fear that I'm not safe, that I'm going to die. So we get him into therapy, and again, for those of you who are familiar with EMDR, eye movement desensitization reprocessing therapy, what we're looking at is your history. We're looking at what you're feeling right now, and then we're floating back through your life to discover where these links started being made. Where did these cognitions start happening? So what he's telling me is, ever since this heart attack, I feel unsafe. I feel like I'm going to die, and my blood pressure's up. I'm anxious all the time. So I start floating back with him in session and learn, basically the question I'm asking is, what are the body sensations you're having when you're feeling this, and what are the thoughts that you're having? I'm unsafe, I'm going to die. Now let's float back through your life, and let's explore some other experiences that you've had all the way through childhood where you felt the exact same way. So we were able to discover 3 big events. The first one was sexual trauma in childhood. Somebody coming into his room that he trusted and sexually assaulting him more than once. Guess what he felt when that was happening? I'm not safe. Okay, flash forward a few years later. He was at an event, standing outside, taking a break, and somebody came up and hit him over the head with a pipe, knocked him out of nowhere, right? Super traumatic event for him. Guess what he felt when that happened? I'm not safe. And then flash forward a little further, there was an event where he's in his own home, somebody was staying with him that his son trusted. This person pulls a gun on him and is about to rob him. Another really traumatic event, but guess what he felt when that was happening? I'm not safe. So, interesting connection, and we make these connections all the time when we start asking the right questions. The heart attack triggered, I'm not safe, I might die, but it wouldn't turn off. The brain was so locked onto that, it wouldn't turn off. And so what I love about EMDR therapy is we start looking at their life, and there are these other huge moments in time where he felt the exact same thing, and it was also locked in there. And so what we did, and I wish I had enough time to tell you what EMDR therapy looks like, but basically you're taking those moments in time, those traumatic events or those adverse childhood experiences, or even traumatic events from adulthood, and you are reprocessing them. So we do that by using the therapy paired with either eye movement rapidly back and forth or other types of bilateral stimulation of the brain, which sounds so bizarre, and it is so bizarre, but it works beautifully. So what we did with this person was we were able to reprocess those 3 big events from his life that were traumatic, that were locked in there, and that were contributing to the feelings of being unsafe, that were causing him to be keyed up and tense and, all the time. And that was 5 sessions. I think he's about to finish his fifth session, and he's ready to go back to work. His anxiety is way down. He is in a much, much better place. That's how quickly that type of trauma treatment can work as well. So you can imagine, as you see this kind of picture come together, how beautiful that can be if we work together to make those connections. Because I'm not sure that if we weren't thinking in this way and we weren't, aware of this, I'm not sure we would have made those connections. But that's the beauty of multidisciplinary team. That's the beauty of trauma-informed care. That's the beauty of understanding the ACE study, working with medical providers who understand that there's more to hypertension and heart disease and STDs, and there's more to it than just the physical aspect of it. So I love that. That's an excellent success story, and we have many of those where it happened exactly the same way. We would have never identified that person as a person in need of trauma treatment if the medical provider had not seen that and called us and said, "Hey, I think we need to work together on this one. Something else is going on." We dig deeper, we treat that issue, and now his health is improving rapidly. And he's ready to go back to work. I forgot to mention that he had to take off work. He couldn't even go to work because he was just so keyed up and so uncomfortable all the time. And so again, that's just one model. That's the model that we're using, but it is working really well for us. So I wanted to share that with you. I encourage you all, to consider similar models, or even, to reach out to people who are using integrated behavioral health and see how you might be able to do that in your organization. Reach out to me. I'm happy to share more about our models with you. Another thing that you can do, there's a film called Resilience, The Biology of Stress and the Science of Hope. Has anybody ever heard of this film? Okay, awesome. It was done by Robert Redford's son and some other people who were involved in the ACE study. And it is a pretty awesome depiction of the ACE study and how you can integrate it into primary care to help improve health outcomes. There's one clinic in California, I think it's California, who has done this beautifully. It's a doctor that started it, and she is now universally screening all of her patients with the ACE questionnaire, talking to them about ACEs, and then treating them accordingly and making connections, to mental health providers. And their outcomes are unbelievable at how their unhealthy risk factors have gone down. So this is another thing that you can do if you're interested in learning more and you want your organization to learn more. This film is circulating in Oklahoma City right now. There is a organization, the Potts Family Foundation, who has the film. And if you would like to show it to your organization, you can actually reach out to them and request a copy of it, request a screening of it, and they will bring it to you. Our clinic has a screening of it coming to us next month. And so this is yet another way that we're going to show our entire multidisciplinary team how this is affecting our patient population and how we can work together to improve those outcomes. And so, again, the name of the film is Resilience. It's the Potts Family Foundation, which can be found at pottsfamilyfoundation.org. If you're interested in that film or want to learn more about it or maybe want to bring it to your organization, that's another way to get the word out about this information. Do you all have any questions? That's pretty much everything I have for you. Okay, awesome. Thank you so much.
So I'm thankful that Summer was able to come and talk to us about hypertension and mental health. Oftentimes there is a disconnect. What we have found in the programs that we have is that the services sometimes are not available. So we're able to identify that there are some mental health needs, but then where are the resources to be able to address those? And I'm very thankful that she was able to mention the adverse childhood experiences because AIP currently has a project looking at specific risk factors that impact American Indians and Alaska Natives. And we are actually working to try to get the information out into more Native communities, stressing the importance of doing ACE, and then also being able to provide some resources. So Summer, do not walk away because I want to chat with you. So up next, we have some additional staff from the Oklahoma City Indian Clinic that are going to talk to us about their blood pressure program. So Stacy Delan is a nurse case manager at the Oklahoma City Indian Clinic, and she has been there for 3 years. She's been a nurse for 7, and she is part of the Ponca and Winnebago Indian tribes. We have with her is going to be Tiffany Griffin, who is also a nurse case manager at the Oklahoma City Indian Clinic, and she has been there for 3 months, but she's been a nurse for 11 years. And finally, they will also be joined by Rochelle Plummer, who is an adult health promotion, disease prevention dietitian at the clinic, and she's been there for 2.5 years, but she's been a dietitian for 5. So please join me in welcoming them to the stage.
Good morning, everybody. Are you guys awake yet? Is the coffee set in? I know mine is. So we are going to go over our PDSA that we did. I don't know if you guys do PDSAs in your clinics where you work at, so I'm just curious if you guys could raise your hands if you guys know what PDSA is. Okay, good. We have about half the people here that know what PDSA is. So for those of you that don't know what PDSA is, it's a plan that our quality improvement does through our clinic to encourage our staff to increase our GIPR measures. So this is something that we did at our clinic as far as to help improve our GIPR measures in the Million Hearts. Our QI committee split up different people in our clinic to kind of oversee different GIPR measures, and we titled them as champions, as far as we want you to be the champion of this group and improve this measure. So I was one of the lucky people chosen to be a champion of the Million Hearts, and so I'm going to go through and kind of explain what I did and what the clinic did to improve our Million Hearts information. Just a little overview for you guys. The Oklahoma City Indian Clinic has 177 employees. Our user population is approximately 20,000 patients. We serve more than 220 federally recognized tribes. We also use the same eligibility requirements as the Indian Health Service, so they must be a member of a federally recognized tribe. We use the same data reporting system as Indian Health Service. Just so you guys can have a little visual of our clinic, we have our medical department, and since Summer just presented as far as their department, so you can kind of have a visual of where we're located and behavioral health is located. We're in the Corinne Half Moon Medical building, and then across the street is our Everett Rhodes Medical building, and then we're actually kind of catty corner to the Everett Rhodes. It's like literally you can walk from one building to the other. So we're very close. We're not really far away. This is our strategic plan, our mission and core values. All of our staff members have this on their name badges. So as far as one of our things that we were trying to improve, as far as all our staff members to kind of have it memorized, because the whole purpose of one of our core values was to, as far as lean process, I don't know if you guys are familiar with the lean process. It's pretty much improving micro changes in your clinic to make a big improvement. And so one of our lean processes is kind of also a PDSA too, as far as you want to make changes to make a big change in your clinic. Some of the services that we offer, we have medical, our Harmony Pediatric Clinic, they're also across the street also, young adult clinic, and we have pediatric endocrinology. We also have a new adult endocrinologist that has just started with us. We did have a cardiologist at our clinic, but unfortunately we do not currently. We have podiatry, rheumatology, our radiology lab, dental, optometry, public health, behavioral health, diabetics, specialty care, wellness center, health promotion, disease prevention, and pharmacy. So even though our buildings don't look really big, we have a lot of people housed in our clinics, and we do a lot of things. Just so you can kind of see how our providers are split up as far as treating our patients, we have several different teams. So we have 3 providers in their gold team, red team, blue, sage, pink, gray, the Harmony team, and then our specialty people that come to our clinic. They're not there on a regular basis. They come once a month, or they practice maybe 2 days out of the week. We have 11 adult medical providers, 6 specialty providers, 4 pediatric providers, and some of our staff have been there for over 20 years. Just so you guys can see their mugshots, this is on our website. So if you guys want to ever check out who our providers are, and also we have this so our patients can kind of identify who their provider is. I don't know if you guys have the issue of your patients calling on, like, I don't know, the guy with no hair or the lady with brown hair. And so we have this on our website, so it helps our patients identify who they need to call or who they're trying to get in contact to whenever they have questions regarding any of their medical care. And this is our lovely nursing department. We have they're not all pictured here, by the way. Not all of them. We couldn't get them all in that picture. They didn't want to get in there and smile. But we got most of them in there, and we have a very large nursing staff. Crossing over into our PDSA information, this was actually presented in like a health fair style in our clinic. We once a month, we'll have admin days where our providers can get caught up on paperwork, so we close the clinic down. There was one day that we specifically had a fair style where all the departments set up posters in a fair style where everybody could walk through and kind of see the information on a poster board. And so this is some of the information that was on our poster board that our other clinic staff could see. And this is not something that patients saw, by the way. This is clinic staff, our board of directors. We had some invited guests from outside of the clinic also. And so on ours, this was our plan as far as to improve our million hearts. Let's see. The what was blood pressure management affected by a distribution of wrist blood pressure cuffs. Who was our patients that had elevated blood pressure of over 140/90. We collected data starting at the beginning of 2017, and we finished our data collection at the end of the year. And then, of course, this was specifically in the medical department that we started this, but we expanded to other departments too to help gather this information. And so at the beginning of the year, I don't know, is anybody here from the Lawton Indian Hospital or Clinic? Nope? Okay. Well, I just want to do a big shout out to them. They actually had some wrist blood pressure cuffs that they weren't utilizing, and they asked us if we wanted to use them and hand them out to our patients. And of course we said yes. Who turns down free supplies? So they donated 100 wrist blood pressure cuffs to us. And then what we did was, with those blood pressure cuffs, we started a log when we first started handing them out, as far as the patients we handed them out to, what their blood pressure was when we handed it out, why we handed it out too, because not everybody got a blood pressure cuff just because they had a high blood pressure. We had patients that they needed that monitoring. So like they had a low blood pressure. They just weren't really good at taking medication. So they had other reasons why they handed out that blood pressure cuff. It wasn't specifically you had a blood pressure over 140/90. And then of course we did education for our patients. That was the nicest thing is these blood pressure cuffs. Here's a picture of them so you guys can kind of have a visual of what they are. They're wrist blood pressure cuffs, and so they're small, about this size. They fit in a little carry case too, and they're battery powered. They also have color coding. This was the nicest thing. So I know a lot of patients have a lot of issues with illiteracy. If you give them a whole bunch of information and you're in there and you're battling off 140/90 and make sure it's staying under this number, and then you go for the pills, and then you go through all their other medical history, most people, you lose them after a certain amount of time. They just say, okay, I'm ready to get out of here. They're ready to go. So the nice thing is this is color coded. So the providers would identify, or the nurses, anybody who came in contact with taking a blood pressure, they also had the ability to go and get a blood pressure cuff and hand out to the patient too. So whenever they gave education, anybody who gave it, the nice thing is whenever they gave this information to patients, they could easily say different colors. The red is obviously hypertension, pre-hypertension, and normal. And these numbers, of course, are a little, since we've had a new change in our American Heart Association guidelines for the blood pressures, it's old, but still the information is still valid as far as if you're having a high blood pressure and it's turning red, we definitely want you to call your doctor, set up an appointment, or at least call us in general and let us know that your wrist blood pressure cuff is turning red very frequently, and we need to get you evaluated for change in medication, diet, exercise, something's going on and that's causing you stress, that's making your blood pressure go up. So it was really nice having this little color coding. And just so you can see what they're seeing when they take their blood pressure, so for example, if they took their blood pressure and it was high, you can see how the color coding changed on the blood pressure wrist cuff where it turned red on the top. So this is what the patient was seeing on their side. If it turned red like that, they would make sure to call us and let us know that it turned red and let us know. Because before we start handing out these cuffs and we tell them, when it's over this number, we want you to call, and they didn't have a blood pressure cuff or they never went and bought one, they would never know. They would never let us know. And the nice thing about these cuffs, they store 1,197 blood pressure readings. So whenever patients come in and we ask, how's your blood pressure going? We ask them to bring this cuff because they're like, oh, it's great. And then we're holding this little blood pressure cuff and we're going back through their numbers and we're like, it's really high. I don't think you've been monitoring or you've been reading these numbers right. So this is a really helpful tool for the providers also, because whenever people, they think they're doing okay, we have something that we can actually check back and make sure that their blood pressures are actually what they're telling it is. Also, it has automatic irregular heartbeat arrhythmia detection, and then a push button access to average blood pressure readings. So that's a nice tool also that anybody can utilize, the patient or the provider or anybody who's checking that blood pressure cuff. Also, the providers, whenever they came in, they did the education as far as medication changes, the importance and adherence to the medication regimen. And I'm glad to be here and glad to hear your other presentations, because some of the information that you guys have presented in your presentations earlier is really helpful as far as some of the things that you're doing, and as far as the way you guys are taking your blood pressure. You uncross your legs, you make sure that they, educate them as far as taking their pills right before they come in and put it on your letters and stuff like that. That's all good information too as far as our clinic, and I'd love to incorporate some of that into ours, because we do this also, but some of the methods, the way you do it, of course, makes a big difference in your numbers. So, of course, and then we try to do multidisciplinary approach, try to include other departments as far as your education and reaching out to the patients to address other parts of their lifestyles, because, blood pressure is obviously not affected just by medication. So as far as Summer just presented, behavioral health makes a big difference too. And then, of course, next is diet. Diet makes a big change as far as blood pressures, which we provided Healthy Hearts Education, which was a dietitian consult that we sent to our dietitian, which leads me into Rochelle Plummer. She is our registered dietitian, and she is in our Adult Health Promotion Disease Prevention Department. She's been a dietitian for 2.5 years at our clinic, and she's also been a dietitian for 5 years. So I'm gonna let her kind of go into as far as our Healthy Hearts education that is given to our patients.
Hi, everyone. My name is Rochelle. Like Stacy said, I am one out of 6 dietitians at the Oklahoma City Indian Clinic. We actually have 2 in our BRAID program, which is our diabetes program. We have 1 in our STAR program, which is our pre-diabetes program. And then we have 3 in my department. My department's called the Health Promotion Disease Prevention Department. I'm actually the adult dietitian. I specifically educate patients on non-diabetes stuff. Hypertension is one thing that I see a lot. I have also a pediatric dietitian in my department, and then my director is also a dietitian. And we also have 4 personal trainers, and we're getting a 5th one next week as well. But like Stacey said, we have a Healthy Hearts consult that is sent to me. This is when our patients have hypertension, or it can even be for hyperlipidemia, high cholesterol. So there's two things that can happen when the patients are sent to me via Healthy Heart consult. One, they can come see me individually, and I'll kind of break that down here in a second. And the second is a group class. I teach a Healthy Heart class at least once a year, sometimes 2 times a year. So again, the providers can send me the Healthy Hearts consult. I can promote the Healthy Hearts class to our patients, or sometimes, or last time we did the Healthy Heart class, we sent out a letter to all of the patients that had seen a provider within a year that had hypertension. We mailed a letter to them saying that they qualified for this class. If they came to this class, they would receive a blood pressure cuff, and you'd be surprised how much that really motivates people to come to classes. All right, so my one-on-one consults. So when providers send me a Healthy Heart consult, I call the patient, I tell them, hey, the provider sent me this consult. This is what the consult's for. Sometimes the providers have talked to them, sometimes they haven't. So sometimes I'm the first one that gets to tell them about it. But my initial consults last about an hour. I get to know patients. Rapport is a big thing with me. Patients aren't going to want to come see a dietitian just to get education the whole time. So I spend a good amount of time building rapport with my patients. I go over any labs that the providers have done. Then I do my nutrition education, which I try to make a lot shorter than my report, because kind of like Stacey was saying, when you're in there with the patient, that kind of stuff can be really overwhelming to them. So I try to leave my nutrition education not my whole consult, if you know what I mean. And then we set goals. Usually I set 2 to 3 healthy lifestyle change goals with my patients. With my goals, I like to make them ideal. So I don't want to, set anything that can be unachievable. I want them to be able to achieve it. And I make sure it's measurable. Because if it's not measurable, who really knows if they met that goal? And then my follow-up consult. So the follow-up kind of depends on the patient. If I can get my patients to come in every 2 weeks, that's great. But they're usually about monthly. They come in, and it's a lot shorter of a session. We do 30 minutes. We discuss the goals we set last time. We do any other nutrition education. So let's say they came and saw me for hypertension the first time. If they come in and see me again and I notice they had high cholesterol, I'll kind of hit that next time. Again, I don't want to bombard the patient with a ton of information. So I try to choose certain things to talk about and not overwhelm them. We reevaluate goals, and then I try to get them in 1 to 2 times per month for as long as really the patient will see me, is what I do. So my group consults. This is where we mailed a letter to all patients that had come into the clinic, seen a provider within a year that had hypertension. I did a 4-week class for them. Again, if they completed this class, if they came to every session, they would get a blood pressure monitor at the end, which I got from Stacey. First week was intro to heart disease. Second week, we talked about high cholesterol and diet. Third week, we talked about hypertension and diet. And then the fourth week, we did a cooking demo, which is actually a lot of fun. So attendance definitely improved with the incentive of the blood pressure cuff, because I had offered a Healthy Heart class before the blood pressure cuff was offered to me, and I definitely did not have the attendance I had whenever I was able to offer a blood pressure cuff. I had a much better attendance. And I made them wait till the very last class to get their blood pressure cuff. They came too. So obviously diet does have a lot to do with blood pressure. So just a few things that I teach in my clinic is the DASH diet. So DASH stands for Dietary Approaches to Stop Hypertension. Of course, number one thing you want to do is limit your sodium. So I usually tell patients in between 1,500 to 2,400 mgs per day of sodium. And that kind of sounds like an overwhelming number. So when I'm talking to my patients, I tell them if a food item has more than 200 to 300 mgs per serving, it's probably not going to fit in that 15 to 2,400 range. So that's kind of easier to break down than the big range. We talk about fats. We talk about good fats versus bad fats. We talk about maintaining a healthy weight. And then I give them a list of foods that has recommended foods and then not recommended foods. And we kind of go through those and talk about better options at the grocery store. All
right. Thank you, Rochelle, for that. Next, after they get all this multidisciplinary information from all our different teams, we also included our dental department. When they come in, they also get blood pressures by the dental department. So I went around to different departments and actually taught them how to take blood pressures and manual cuffs, and we bought different departments manual blood pressure cuffs, stethoscopes. We taught the staff on how to take blood pressures, and then of course what to do. As soon as they get a high blood pressure, they were supposed to call the medical department, because we wanted those patients, even if they got caught in a different department for a different reason, if they had a high blood pressure, we wanted them to circle around to get it addressed. So after our data was compiled, I did this in an Excel sheet as far as all the blood pressure cuffs, and these are primarily the patients that were having issues. So then you can kind of see it, the result of as far as the blood pressure cuff distribution and the impact it had on our patients. So as you can see on the red line on the very top, this was the blood pressures that they had before we handed out the blood pressure cuff. And then the little orange line in the middle, this is the 140 systolic. So you can see these are all the ones that had systolics over 140. And you can see there's one really high one over there. So I'm very, very happy to see that really, really high peak over there actually came below our line also of the 140. And underneath you can see after we had them come back. This was not just like one visit after their initial, we gave a blood pressure cuff, they came back and it was dramatically improved. This was possibly 2 or 3 visits, and our doctors would have them come back for nursing appointments also. So this is something the nursing department would help address also, because I don't know if you guys have this issue also, but as far as patients getting in with your providers, the appointments are very limited sometimes. You know, they call and they say, I need an appointment, my blood pressure's really high, and they you know, our scheduler is like, well, we have an appointment next month, you know. So to increase access to our providers, as far as for patients with high blood pressures, they could schedule a nursing appointment to have their blood pressure checked, and then the nurses would report that high blood pressure to the provider in between regular patients that are scheduled with the provider. So then the provider could easily make a judgment call as far as the medication needs to be changed, or, you know, their blood pressure is okay and they can continue with their current regimen, and they could just follow up on their next appointment. So after their appointments that they had with nurses, doctors, or any other staff that they came in contact with, and a blood pressure was logged, we saw a big, not increase, actually blood pressure, you want it to go down the other way, so decrease as far as from the systolic, and it came down. So obviously the blood pressure cuff handout with education, multiple departments giving education out and helping our patients get access to care made a big improvement in our clinic. And as far as continuing, we are still handing out blood pressure cuffs. So another shout out to Lawton Indian Hospital. They're supplying us with any extra blood pressure cuffs that they have, and we haven't ran out. We keep getting a steady supply from them, so that they've been very helpful in this. Clinic to clinic help and generosity is always well appreciated. Then, of course, last year in October, the new guidelines regarding lower blood pressure definition was implemented from American Heart Association and Association of American Cardiology in October of last year. So whenever that information came out, also, the providers were educated by our chief medical officer as far as the identifying patients with blood pressures that was 130 and over 80. And so our blood pressure cuffs, we started handing them out a little bit more because, of course, since the guidelines has changed, we also adapted too. And of course, by handing out these blood pressure cuffs, a cost savings for our patients was about $4,000. So our patients greatly appreciate that, because, you know, you come in for your appointment, and then when you're told you have to go buy another medical piece of equipment somewhere else at a different place, most people are not going to want to go to Walgreens or Walmart and buy a blood pressure cuff. And the one that I showed you the picture of, that one at Walgreens is only $33 as far as what I found online. And even though they're cheap, you know, people, they don't want to spend their own money. They just, you know, don't have the time. You know, there's several excuses. So this is one way where you can stop them and be like, you have it. You don't have an excuse now. You know, we've given it to you for free. So, and just so you can see our results, as far as the other graph, and this is just kind of our percentage, we had a 54.4 improvement of our blood pressures. So I'm very happy to see that we had a very good result from this. Also, so you can kind of see our GIPRA results. So our GIPRA is not currently reflective of the current 88 AH guidelines in this little graph right here, but we did have a decrease from, I know you guys can see this little X right here at the end of our graph. That little representation is because we had our denominator change in our GIPRA. We not only would, originally it was just in our area, we were including the information from just in our area. So then we actually increased it to any patient that ever came through our clinic. So like if somebody came from Missouri, stopped in and said, hey, I need my blood pressure meds, we give you your meds, we took your blood pressure and they left, we are still capturing that information. So that's why you can see a big drop, because we included everybody after that. And our internal target was 70%. And as you can see, the blue line is where we were staying because of all of our work we were doing, 75%, 74, 75. And so it was, we were doing a really good job as far as our blood pressure is working pretty well. And at the very, very bottom, that's the national target. So of course we were doing pretty good as far as our meeting the national goals too. Just so you guys kind of understand, just a picture representation of what our fare was. I said it at the very beginning as far as what we did. This is our STAR group. So as far as the PDSA fare, let's see. During this fair, our employees were able to view the presentations in the fair style and voted on by all the employees. So this healthy competition between your department also increases your numbers. The best PDSA selected was the STAR referrals, and just a little information on theirs. They wanted our providers to increase their referrals to their department because they, of course, are trying to increase education to our patients as far as working out, healthy lifestyle. And they had lights and they had like music going, and so they really got it interactive as far as wanting to get our providers really amped up about winning this challenge. They gave out backpacks and water bottles and all kinds of stuff that the providers made a lot of referrals to the department. And so they won the best the best PDSA for their presentation. And then, of course, the medical department presented our blood pressure cuffs. And as far as what we do, and just, a short little, walk by, and we give out the short information as far as what we did, and we got the best in show for the PDSA on that one. So that's why I'm here in front of you today, as far as presenting our information and as far as what we made a difference in our clinic. And then we also presented at the IPC face-to-face at IHS as far as our information and our PDSA also. And that concludes my presentation, so if you guys have any questions. And just in case you guys have any questions for me personally, this is our contact information also. So, and thank you very much.
Okay, well, let's thank them. So one thing that I wanted to reiterate about this event, which is really coming out in some of the presentations, is for sure the resources and the partnerships that are being expressed to us today. That is something that we really focus on at AIP, is finding, stories such as this of successful efforts of controlling not only blood pressure, but addressing mental health and other issues. So if nothing else, please hit up the people that are in this room today, and definitely contact us for any of their information or the resources that you see today. Okay, sorry everybody, that was a little bit more extended break than what I had planned, but that just means that we are having some good conversations while you're here, so I hope you enjoyed it. So up next, we have Heather Carter, who is a cardiovascular disease and stroke prevention consultant with the Oklahoma State Department of Health. Heather works with grants statewide and for various counties to promote prevention and to provide technical assistance to lower the percentage of Oklahomans diagnosed with heart disease. She has worked in the health and wellness field for more than 17 years and holds a bachelor's in exercise physiology and is currently pursuing her master's in health studies. Presenting with her today is Lieutenant Commander Justin Wilcox. He is a clinical pharmacist for the Choctaw Nation Health Service Authority at the McAllister Clinic and has been employed with them for 6 years. He graduated from the University of Oklahoma College of Pharmacy in 2012. He has been a commissioned officer for the United States Public Health Service since October of 2013. Join me in welcoming them to the stage.
Okay, thank you. All right, thanks. Hello. Okay, so basically today I'm just going to be speaking about what we're doing in the state of Oklahoma for blood pressure control. Just a few facts about hypertension in Oklahoma. Oklahoma has the second highest rate of death due to heart disease in the nation, and the 10th highest rate of death due to stroke in the nation. We rank 43rd for percent of adults reporting that they had a heart attack, 40th for percent of adults reporting they have had their blood cholesterol checked within the past 5 years, 41st for percent of adults reporting they have high blood pressure, and 37th for percent of adults reporting high cholesterol. So for detecting hypertension in the undiagnosed patient, as you know, we first want to triage the patient, blood pressure, pulse, respirations, etc. Is the blood pressure elevated? If so, let the patient know and have patient relax and sit quietly for 1 to 3 minutes, and then check again. If the patient is already diagnosed with hypertension, repeat the vitals after 1 to 3 minutes and document. And then we want to proceed as usual with customary workflow regarding patient evaluation or evaluations and recommendation for medication changes, etc. If the patient is not currently diagnosed with hypertension, then we want to begin the Chile protocol. So with the Chile protocol, CH, that's for check the vital signs a second time, at least 3 minutes after the first one, and then document. I, inquire if the patient's blood pressure is still elevated, document. L, let the patient know if their blood pressure is still elevated and provide some brief education regarding the risk of uncontrolled blood pressure. L, let the provider know. Flagging them in the EHR is great, but adding a red clip to the door is even better. I, implement a reminder mechanism to ensure you don't lose the patient to follow up. And this material is provided by OFMQ, which is the Oklahoma Foundation for Medical Quality. Okay, so this is basically just an algorithm, care coordination model that we have used with our version of the Million Hearts, which is Heartland OK / DP OK. And so basically it's just starting with the healthcare provider, and based on if the patient has hypertension or diabetes or pre-diabetes, then we give you like the Chile protocol here, and then the criteria for diabetes or pre-diabetes. So with that being said, and all depending on the local county health department and the resources they offer as well, what we would like to be done is the provider can refer these patients, whether they have hypertension or diabetes or pre-diabetes, to that local health department. And the local health department can, educate the patients, have weekly checkups with the patient, and these are all going along the parameters that the provider has set for the patient, whether they have high blood pressure or whether they are diabetic or pre-diabetic. And some of these local health departments may have pharmacists, RNs, RDLDs, health educators, or a community health worker. And as far as on the diabetes side, some programs that are offered could be the DEEP program, DSME, and NDPB. So then when the results have reached the normal range set by the provider for either blood pressure or the blood glucose, then the local health department will then loop back around to that provider, as well as, send them a note as far as like the logs that have been taken for their blood pressure and their blood glucose, just to let the provider know, what they have been doing since they have been working with that patient. Okay, and that's what I have. And next, I'm going to have Lieutenant Commander Justin Wilcox.
My name is Lieutenant Commander Justin Wilcox. I want to thank you all for inviting me to come up and speak with you today. What I'm going to do is give you a brief overview of a hypertension management project that we've been conducting at the McAllister Health Clinic within the Choctaw Nation. So a little bit of background. This is something that we kind of had in mind for a couple years, but we didn't really act on yet. We wanted to find a way that we could help our providers take a little bit of the weight off of their shoulders. We do run a anticoagulation clinic, and we wanted to find a way that we could assist them, be it hypertension or antilipidemia, something that we could do to assist them. So it was just kind of an idea we had thrown around, tossed around. So a little background on the clinic. For primary care purposes, we have 6 providers. There are 3 MDs and 3 mid-levels. Within the pharmacy, we have 5 full-time pharmacists and 4 technicians. Other services that are offered at our clinic, we have pediatrics, dental, behavioral health, optometry, imaging, laboratory. The behavioral health and the dental will kind of play into this project as well. So what we did was, to begin, we tried to identify the patients using our GIPR reports that had a diagnosis for hypertension but were uncontrolled. What really started this project was the State Health Department and ASTO, which is the Association of State and Territorial Health Organizations. They came to us with a grant opportunity to try to implement some type of scalable and replicable model that they could use at other sites and potentially within the public to be able to help better control blood pressure in our area. Like Heather said, Oklahoma has a high rate of cardiovascular disease, especially in our area. So Pittsburgh County, where McAllister is located, is especially high. So a little bit about kind of our brainstorming processes. When we first had our few meetings, we decided that there were kind of 3 ways that we could capture patients to be referred down to the pharmacy for monitoring and management. So first would be just kind of your typical patient. They're seen by their provider already, they're established, but for some reason their blood pressure is not at goal. It might be very close. It might actually be at goal, and the provider just wants them to hear education from another aspect, another viewpoint. So they will refer them down to the pharmacy where we will help to assist in educating them and managing them. Patient number 2 are the patients that we are able to capture from other services within the clinic. So maybe they are not established with a primary provider, but they see behavioral health every 3 or 6 months. So typically when they're seen by behavioral health or our dental department, what they will do is check their blood pressure and write that on their routing sheet. When they are sent down to the pharmacy to fill their medications, what we'll do is check that blood pressure. If it's elevated, we'll go back in their chart and see, is that historically elevated or is that just a one-time occurrence? If so, we'll speak to them about hypertension, educate them briefly, and just let them know that they need to establish with a provider and kind of keep an eye on that and keep it in check. And then ideally, what we wanted to do is also try to capture some patients that were not being seen at the clinic. So patients that might be going into the local health department, if they caught them with uncontrolled hypertension, what they could do is send a referral to the pharmacy, and we would contact those patients and try to schedule them in so that we could assess their blood pressure needs and educate them a little bit and try to get them to come in and establish with one of our primary providers. This part of it has not really worked out as well as we thought it would, and I think it's not due to the health department's fault. It is due to, I think, just our patients' population in our area is really good about coming into our clinic. So they already utilize our services pretty heavily, so we're capturing most of those as it is. So this is a little diagram and workflow. It's pretty busy, but it just kind of breaks down patient 1, patient 2, and patient 3, kind of the entry points into our clinic to establish with our providers and also to be referred to the pharmacy. So what we tried to set up was a type of clinic that the providers could refer the patients down to us, and our clinic is fairly busy, so usually patients are not able to get back in with their provider for at least a month, but a lot of times they put them at least 3 months out. So by sending them to pharmacy, we can kind of help to increase the amount of time that the provider has to focus on other areas. So we can bring them every couple weeks, 2-4 weeks, and assess their blood pressure and make recommendations back to the provider, and also educate the patient and make recommendations to them on lifestyle modifications that they can make. Our initial visit typically takes about 30 to 45 minutes. We have had some take longer, just depending on the patient. A lot of them are pretty inquisitive. We make sure to let them know how long that the visit will take. That way they kind of know what to expect. As somebody mentioned earlier, you get somebody in there, you're talking to them for 30 or 45 minutes, they start to lose interest if they're not already expecting that time. So this is a copy of our hypertension flow sheet on the left. So it's just basically a replica of our template that we have within our EHR. And it really dictates how our visit flows with our patient. And we go through this with them, and we hit each aspect and kind of do a brief overview of everything with them on their initial visit. So visit structure, first thing, like I said, is the orientation to the clinic. We let them know what we're doing, what the clinic was set up for, what we're expecting as far as how often they need to come in. We try to educate them and assess their understanding on hypertension. So we give them a brief overview of what hypertension is, what that disease state is. We try to make sure that they understand a good baseline of that. We typically have them watch a video. This was placed out by the CDC. It's available on YouTube. It's really short. It's about 1.5 minutes long, and it does a good job at just kind of setting up a good baseline knowledge for our patients. And then we talk to them kind of about the goals and expectations that we want to attain, and then also that they want to attain from this clinic. So it's voluntary. They don't have to participate. So that initial visit, we really assessed their desire and their need and want to improve their lifestyle and their blood pressure. We give them a patient packet handout, and I have a few slides in here that includes some of those photos, those diagrams. This is from the American Heart Association, just kind of a what is blood pressure basics. We go over this with them just to kind of make sure that they know where they fall at and which category, and kind of let them know what a normal blood pressure is supposed to be. The first thing that we do typically as far as screening is tobacco and alcohol screen. So we talk to them about their tobacco use, whether it be smoking or smokeless tobacco, and we always recommend smoking cessation. We do have a smoking cessation clinic in Tallahena. It is kind of a revolving door process. They have a certain amount of patients they can accept. They're placed on a waiting list, and when somebody gets discharged, they're able to accept somebody back in. So a lot of times we don't utilize that route. We've only had a few patients that have been interested in smoking cessation, so what we can do is either refer them back to their provider for medication, or we can speak to them about the tobacco hotline. We also utilize that. We screen them for alcohol use, make sure that they know the proper recommendations on daily limits. We go into dietary counseling with them, so usually first thing is to assess their diet and see if it is decent to start out with. Some patients are already implementing some type of diet, so really there's not need to change anything. We educate everyone on the DASH diet, the appropriateness of sodium intake. We try to really hit hard on them with soda and pop and energy drink use. A lot of individuals don't really think of those calories they get from soda or pop as calories in their day. They just see it as a drink. So there have been numerous individuals in our part of the state that they drink a lot of pop. I had a lady come in that actually she was drinking about a 12-pack a day. And when I broke that down and told her how many calories she was actually getting from that, she was really surprised. So I talked her into just cutting it back to 4. So if she was able to do that, she was cutting out 1,000 calories out of her diet a day just in that aspect alone. So just kind of making them aware of improvements they can make in their diet, little things and just goals that they can set to try to work towards improving their diet. And then we also ask them if they are interested in seeing our nutritionist. So if they have a desire to get a little more in-depth education on dietary nutrition, then we have an agreement with our nutritionist to refer them down to see her. We have had a few patients actually utilize that. So the TSET, Tobacco Cessation Helpline, and then also the NIH's version of the DASH diet. And it also gives them a DASH eating plan, so it gives them a day in the DASH diet, kind of gives them a good example of what they can expect if they were trying to implement that. Next, we typically move to physical exercise and physical activity. We try to assess their current levels, see if they're already active. If they are, just tell them to continue that. If not, let them know what the recommendations are from the American Heart Association. Making sure to tell them that they don't have to attain this right off the bat. So we have a lot of people who live a sedentary lifestyle who don't do any physical activity. So trying to get them to do 30 minutes 5 days a week or every day of the week, they're really resistant to that. So trying to set goals that they can attain in between visits to work towards that ultimate goal. So it might take them a month and a half or 2 months to reach that, but as long as they're progressing towards that and working towards that goal. We can also assess their desire to see a physical trainer. So we have trainers located within our wellness centers. Choctaw Nation has done a really good job the last few years with placing and building wellness centers throughout the Choctaw Nation area. We have one located about a mile down the road from the McAllister Clinic, so we have spoken with those physical trainers there, and they've agreed that if we have anybody that needs kind of more in-depth education on a specific regimen, then we can refer those patients down to those physical trainers. Next, we try to talk to them about medication adherence. We assess how well they are at taking their medicines, and then talk with them about issues that come up and reasons why they can't take their medicines. Do they forget it often because of the timing that they're taking it? Is it a side effect that's causing issues? So we talk to them about that, educate them, kind of let them know what to expect. We give them pill planners if needed, just anything that we can do to assist them in improving their medication adherence. We also utilize home blood pressure monitoring, so everybody is educated on proper blood pressure technique, and we also dispense to them blood pressure monitors. So patients who are CDIB card holders who are Choctaw tribal members, they're eligible to be referred to our patient relation office, and they get a blood pressure cuff free of charge. The patients who are not Choctaw tribal members, we have acquired quite a few blood pressure cuffs that we give to them, dispense to them in clinic, and that's something that we've been able to use the grant money that we have received to kind of purchase those and give those to those patients. They're fairly inexpensive, and it's definitely worth the money spent to be able to make them aware of what their blood pressure is running. So they take that home, they take home a blood pressure log sheet, and we ask them to check their blood pressure level at least daily, if not more than 2-3 times a day. And they will bring that back in with them, and we'll assess their home readings and compare that to what we get in clinic. Kind of the last thing that we do as far as attaining information from the patient, we'll pull up the American College of Cardiology ASCVD risk factor calculator, and we'll plug in all of their information that we obtained from this visit and from their previous labs, go over that with them as we're putting that information in, and let them know what their 10-year risk is. So a lot of patients, it's very eye-opening. So you get somebody that comes in, they're kind of younger, maybe in their 50s, and they have a 20% risk of having some type of event within the next 10 years. It really opens their eyes and lets them know that they need to do something in order to lower that risk. And the calculator is really nice. It also allows you to manipulate things within that, and you can kind of show them what will happen, what could occur if they quit smoking or if they improve their blood pressure. Last thing we do is we talk to the patients about a plan as far as what we can do and set goals for the next visit. Typically, we like to see people every 2 to 4 weeks. It doesn't always happen, but we try to work with them and make it convenient for them. So we usually try to have them pick their own goals, because if somebody picks it, more than likely they're more likely to try to strive to meet that goal. We like them to choose a couple, if not 3. If they can only think of one, typically we'll make a couple recommendations and let them kind of choose from that. We'll talk to them about monitoring schedule. So Like I said, typically we like to bring them in about every 2 weeks, especially if a medication change is made. If not, and it's just dietary or exercise, kind of lifestyle modifications, usually we'll try to get them in within a month. Some patients are able to see us the same day they see their provider, but they may be working out of town, so we'll try to set up telephone visits that we can call them and do that over the phone so that they can report their blood pressure readings to us. We'll kind of go over any goals we might have set over the phone and assess that and then make recommendations that way. As far as medication changes go, we will make recommendations back to the provider. Usually we will let the patient know kind of what we're thinking, just so they kind of have a heads up. They continue their current medications that they are on, but we will send a note to the provider with a recommendation, and once we hear back from them, we'll contact the patient and let them know what's been done, and we can either mail those out to that patient or they can swing by the pharmacy and pick those up. The data that we collect, I've got a couple documents on the next slide. We try to make sure that we get all the information that I showed you on the initial visit, and then the follow-up visits are usually trying to assess usually lifestyle modifications and any goals that they might have set. They do receive that patient packet, so it has a lot of information in there. Information on the DASH diet, physical exercise recommendations, tobacco helpline. Reading food labels is another big one, talking to them about sodium content and making sure to kind of hit on fats and how to read those labels appropriately. So early results for our clinic. We started this project back in the summer of last year, but it didn't really hit the ground until January. So this is from about January 3rd through the 29th, which was, I believe, Tuesday. So far we've received a total of 66 referrals from our doctors. Most of those have been from one doctor. I told you earlier that we had 3. We initially started it with one provider, but he had a lot of time off and it didn't really pick up with him, so we expanded it to the other 3. And then it really picked up in January. As of right now, we have 6 pending patients that we need to get into clinic. We usually like to keep it between about 20 to 30 patients enrolled in the clinic because we feel like that's about as most we can take on with all the other activities and the normal function of the pharmacy. To start out, we had some people opposed, so we have had 12 of those 66 referrals just discontinued. 6 of those they came in for the first visit or they were seen by their provider, came down to us. They just didn't want to enroll in the clinic for some reason. 6 of those have been due to no-show or failure to schedule. So patients coming in, maybe they were seen for their first visit, but they were unable to be contacted or they didn't come in for their follow-up. We try to get them back in. After multiple no-shows, we discharge them and try to enroll somebody else in the clinic. Right now we have 28 active patients, and we have to date had 21 with controlled blood pressure that we have discharged from the clinic. So controlled blood pressure for us is 2 consecutive visits within their controlled range. Most of all the consults that have been sent down have been less than 130/80, so most of our providers are practicing off of those newer guidelines. Total visits since January, we have accomplished 155 total visits, 133 in clinic, and 22 of those have actually been telephone. We have had a handful of people that have, like I said, they go off and they're gone for months at a time, so we've conducted completely over the phone, and we've been able to monitor their blood pressure through their home monitoring and able to discharge them from that standpoint. And with that, that is the end of my presentation. Any questions?
Okay, Justin, you just did that great of a job presenting today, so thank you.
Thank you.
All right. So Dr. Becca Leith graduated from the University of Oklahoma College of Pharmacy in 1996 with a Bachelor's of Science in Pharmacy. She is a member of the Chickasaw tribe. Becca is a native Oklahoman who grew up in southern Oklahoma. Prior to the College of Pharmacy, she attended the University of Oklahoma in Norman. Becca began her pharmacy career as a retail pharmacist and worked in chain pharmacy settings for 12 years. She took the position of staff pharmacist at the Indian Health Care Resource Center of Tulsa in 2008. She has been providing compliance review, medication counseling, and medication reconciliation for the clinic since 2014. Dr. Leith created, developed, and implemented this program to enhance and increase communication between provider and patient. Becca was the winner of the 2016 Area Directors Customer Service Award for the Oklahoma Area Indian Health Service and was named the Oklahoma Primary Care Association Clinician of the Year for 2016. Becca currently lives in Jinx, Oklahoma with her husband, Rob. She has 2 children, and I love this part, 1 perfectly adorable granddaughter, right? Because aren't all grandchildren perfectly adorable? So please help me welcome Dr. Leith to the stage.
Well, after that, I certainly hope I'm worth the wait. I'm a little nervous. Having graduated in pharmacy school in 1996 and working in retail, really didn't have much reason to make a PowerPoint presentation or do any of these type of events. However, luckily now I'm in a position where I can, and I'm super excited to share my program with this group. So first off, it is an urban clinic approach to improve patient care through pharmacist intervention. That is the name of my program currently. This is a picture of our beautiful clinic, Indian Healthcare Resource Center in Tulsa. It's just blocks away from downtown Tulsa. We have a dental, optometry, behavioral health, health and wellness, which includes dietitians and exercise providers. There are approximately 16,000 active patient charts at our clinic, and we have 76 of those patients that are currently impaneled to one of our 3 medical teams. We serve all federally recognized tribes, and we have been HHC accredited since 2001, received our medical home accreditation in 2013. So about the dispensing pharmacy. I like to brag on them because they're pretty amazing. They can be relaxed and still fill an average of 900 prescriptions per day. They have, which counts out to about 18,000 prescriptions per month. Oh, that's not 7 days a week. That's 5 days a week, 9 hours a day. The pharmacy we have 3 full-time and 1 part-time pharmacist. We have 7 full-time pharmacy technicians, 4 full-time pharmacy clerks, and 2 robots named Bob and Marley. They also have there are 4 patient contact windows in the pharmacy, including a drive-through which has 2 lanes, and prescriptions are filled only from in-house providers. I'm not sure if every clinic does it that way, but we only fill if our provider has signed off of it and sent to us. This is a list of our current formulary hypertension medications. They're pretty normal. They're all chosen by the Pharmacy and Therapeutics Committee. Of course, according to patient benefit, according to any side effect profile, and also cost effectiveness. For many years, the formulary was chosen mostly because we were running out of space in the pharmacy. We got a remodel, now we're running out of space again. Lisinopril is generally one of the top 5 medications prescribed at our clinic. So to start with, in 2014, I came up with the idea of trying to meet with patients prior to provider appointments in order to try to help increase compliance and take some of the burden off of providers in appointments. So first I searched for patients on every single provider schedule who had 8 or more active chronic medications. I also would meet with established care patients. This was initially. And also by provider word of mouth. So if they came by my office and said, hey, can you come meet with this patient, or sent me a message, then that's how I found what patients I was going to see. Later on, I'll give you a detailed description of how I'm currently choosing the patients that I see. What I do is I call the patient one day prior to any scheduled appointment. I ask them to please come early. We've tried to work it in where I'm on the actual scheduler, but that makes a lot of extra work for the appointment clerks. And the whole point of me doing this program was not to add additional work to anyone else. It was to try to benefit the patient and take some burden off of other people. So I make this phone call. The patient, if I get a hold of the patient and they come in, then I'm averaging probably 6 patients a day right now that I do get to meet with, and it is a 30-minute process. I see them just before the nurse does the triage. Pardon me. So what happens is they wait out in the regular waiting area. I get them, and as soon as a patient room is available for that provider, that's where I go. Then after I meet with the patient, I'm meeting with the provider individually about that patient while the nurse is taking vitals. So this is all happening in the patient room where they will see the provider. Patient doesn't have to go anywhere else. They stay right there. When I'm talking to the provider, I make sure that they are aware how the patient's compliance is, how they've been doing, any specific questions they might have about their medications, and also, maybe this one, I don't see that this dose increase has helped any. I can't tell that this is helping. I can't tell that this gabapentin dose works at all. Maybe this dose works a little bit. I'm kind of asking specific questions that providers don't necessarily have an opportunity to ask. And so that opens the door for discussion. So what all I do when I meet with a patient, I provide medication reconciliation, patient education and counseling, and also compliance review. In medication reconciliation, this is any transition of care patients, specifically established care patients, hospital follow-up patients, or anyone moving from skilled nursing that have been released, or possibly a rehab center after they've been in the hospital. When I meet with them for established care, I'm gathering every prescription that they take, any over-the-counter product, including supplements, and you do have to make that designation because patients don't understand what you mean by over-the-counter generally. Well, that's just my herbal supplement. Well, that's included. Got to get it in there. So I'm adding that information all into the outpatient meds tab in the EHR so that it is available for the provider when they walk into the room. I also, at that point, let the patient know what is on our formulary, because we do have the closed formulary. I let them know what medications of theirs may need to be changed to match what's on our formulary, to really be particular about looking at their specific bottles when they leave the pharmacy, just in case there's a slight change, just because maybe we don't keep the same strength that they're currently on. I also let them know what medications that our providers may or may not prescribe based on my knowledge of the providers and also our formulary restrictions. Another thing I do is the providers will send me hospital records for patients. If they are coming in the next couple of weeks, I will place them on my schedule and see them when the patient comes in. Unless there's an urgent need to get information from the patient, then I call them in advance. So I'm either meeting with them and reviewing their entire hospital record, asking them about any differences between our active med list and what the hospital listed as their active med list, seeing if they have any new medicines that were given to them. Did they fill any of the prescriptions that were given to them? If they left the skilled nursing center, were they given the prescriptions that were left over? Do they have any medicine right now? All of those types of questions I'm asking before the provider even gets into the room. Let's see. I also ask them, were you advised to stop any medications? Because sometimes they don't. There's so much going on at discharge, they don't know what they've been told to stop or not. And then, did you really stop it? Or did you just go ahead and take it anyway? Because you know that happens. So I also, like I said, I update their outside medication list. And that's every time I meet with them. That's the last question I ask. Do you have any prescriptions that you fill at any other pharmacies besides here? If they don't know what that is, then I find out what pharmacy they're filling it out, and I call them to make sure that that information's in our computer so that we always have an interaction check or adverse reaction check. So patient education and counseling. Sorry, I'm old school. I've got to have my outline up here so that I can talk through it. during patient education and counseling, I do specific medication instruction. So I discuss every single active med on their med list. So I have access to the EHR while I'm in the room with the patient on the computers that are in their rooms, and I go through each medication. I ask them about adverse reactions. Have you ever had muscle pain or weakness not related to exercise when you're taking your statin? Things like that. Sometimes they're like, oh, you know, and I'll go, well, you know, if you've got a back injury, that's probably not related to your statin, but it's worth talking to your provider about. Another thing I think is important about the program is it begins the discussion. It starts the questions being asked so that when they finally get in with the provider, maybe they remember something a little differently than what they were talking to me about. Maybe they're a little nervous about our talk. As a matter of fact, half the time when I call patients, they get there and they're like, what's going on? What's happening? Am I in trouble? What did I do this time? So I try to let them know that this is not about being in trouble. This is about gathering information and trying to make sure that we all understand what's going on. I also provide inhaler and respihaler instruction during this. I don't have an official COPD clinic or asthma clinic. That's one of my future goals. I'll show you that later. I mostly, because it's easiest to track the patients, I mostly meet with diabetic patients. But if they happen to be on a medication for any kind of COPD or asthma, I review the use. Amazing the amount of people who have no clue, been an asthmatic for 20 years, use 2 puffs at the same time with their inhaler. It's amazing. So I'm reviewing all of that with them and reminding them that inside the package insert, it does have these instructions in case you don't remember what you and I just talked about. I also go talk with the patient about their insulin sliding scale. So if they're on a mealtime insulin, I'm another person in the room. So the dietitian has met with the patient and explained the sliding scale. I come into the room, I meet with the patient and ask them a few questions to see if they understand the sliding scale. Also ask them their average shot per day. I also ask them things about what is your maximum shot that you've had to do in one sitting. Just details like that that the provider wants to get to but may not have a chance to once they walk in the room and the patient says, oh yeah, I needed to talk to you about. I know this is supposed to be about just one thing, but so that I have a little more time to kind of specifically ask those questions, especially since I kind of take them by surprise a little bit. I talk about dosing schedules. Simplification of dosing schedules can make a world of difference. Patients are taking medications 4 and 5 times a day because they think they all have to be taken separately. So I am able to erase all that information. I can let them know what does need to be taken separately. Yes, you do need to take your Synthroid all by itself. You can't take it with everything else. Or if you can't remember to take your statin at bedtime, take it with your evening meal. Take all of your evening meds with your evening meal. Better to have it at the evening meal than not have it at all. So that's part of what I'm doing when I'm talking to patients. Also, compliance review, which actually, if you've ever been a retail pharmacist, is kind of your favorite thing to do because you can look at a patient and go, yeah, well, you can say that you took this 10 times last week, but you still have 10 pills left. So you shouldn't, and you couldn't. Anyway, I do discuss with patients. I have access to the pharmacy refill software. So I go through the last 90 days of every single patient's pharmacy profile, and I discuss, check and see how late their refills are. So I can take a look at that information and relay it to the patients. Now, I don't talk with them about 1 or 2 days. We're talking about a week or more of late refills. I'm going through all of those with the patient and saying, because our policy in the pharmacy is we'll fill things 7 days in advance, which makes sense. People can get there a lot more easily when that happens. It also could mean that a patient could have 7 days worth of medicine stocked up, or even a little bit more. But when it gets past that 7 days, that's when we really need to look and see what's happening. Why are you missing these medications? So I review that. I provide the patient with real-time information about exactly what medications they're missing. I also advise the patient on ways to get through that, how to fix their compliance. So I've got strategies coming up. Determining barriers to compliance. That's kind of a big one because you can have patients who are saying, I don't know what to tell you, I take my medicine. Or I just don't like it. Well, in the appointment that I have with the patient, I'm able to establish rapport with the patient so that I can finally get to the root of what's happening. So you're not taking this because it makes your stomach upset. Did you tell anybody? No. Okay, well, we'll do that now. Possibly we can change to a different therapy. This is really going to help you out. Hopefully you'll get more medications in this way. I talked to them about the refill process, a very simple thing. It can be a little confusing. Exactly the best way to get information to the pharmacy and get a refill. I'm surprised by the amount of people who want to lay all of the problem with the process. So I figure if you're going to say that the problem is the process, you're going to know what the process is and the best way to get through it. So that's one of the things that I do. I also talk with patients about transportation issues. Our clinic provides refill pickup transportation within the Tulsa metro area for certain patients. So I let them know, listen, you might qualify for refill pickup with our transportation if you can't get here. If they don't want to do transportation or can't use transportation for some reason, we have a medical case management social worker who works with our patients. She can get them bus tokens. I can start that process and let the provider know they need to talk to someone about getting their transportation taken care of. I also talk with them about individual adverse reactions. So like I said, why aren't you taking this? Well, you know, it kind of makes my stomach hurt. Did you tell anybody? Well, I just thought that's what it did. Well, it doesn't have to. So let's talk about that. I also talk about patients who have resistance to take their medication. Now, nobody knows anybody like that, right? Nobody here, like the Choctaw Nation gentleman, Wilkins, right? Sorry, Wilcox. He mentioned that he had some patients who just didn't want to be involved in the program. Well, none of us are like that, right? No, that's too much of a problem. I don't want to think about it. Or I don't want to swallow pills. So I talk to patients about these type of things. Like, you don't have an option really right now. And when they hear it very frankly from me and from their provider and from the dietitian, then eventually they get it. You know, you can do this. And also, next, strategies for compliance. So since this is my favorite part, I do have specific strategies I try to help patients find out for compliance. I look to see, I let patients know, listen, you can do anything that you make a priority. If you make it a priority to get your medications in every day, you will do it. If you don't make it a priority, then it's probably not going to happen. But I'm here to help you when you do. Another member of the healthcare team that cares about what's happening with them and lets them know, here's my phone number, call me if you have questions, here's who you call if you want to know about this, here's who you want to call if you know about that. I also provide pill planners to patients. A lot of people think that's only for old people. And all the healthcare people in here are going, no. So I use the example. When I have people who are kind of reticent to use it, some of them are just hard-headed and don't want to do anything like that. Others are like, well, I'm not. That's what my mother does. So I provide them a planner. I give the example. Birth control pills all have the days of the week on the top. Those are for young women. Why do they have the days on the week? Because it's important to take it every day. It's not like they're too old to remember. It's just very important. So right now, at this time of your life, getting these medications in every day is important. This will help. I let patients know that it increases efficiency. They only have to open and close bottles 1 day a week versus 7 days a week. No hunting and pecking through any of the bottles. This is something that I talk to every single patient about. That's what I include as best use instructions. I also have them fill it in the same day of the week. That does multiple things. That allows the patient to have a reset, if you will. So if they misunderstood the directions when they left the doctor, they're going to be looking at the bottle again a week later. It's not every day a repetitive motion. This is the white pill. I take that 3 times. They stop. They look at the bottle. Okay, this is so-and-so. Oh, well, you know, I'm pretty sure I only took that once a week last week. Maybe I should take it as it's directed. So they have a reset. They can also tell if they missed any pills in the previous week. That way they can change their schedule if they need to, including the fact that it gives them some sort of control over their medications and their diseases. They can look at it 1 week at a time versus having it be this giant thing that lasts a lifetime. How many people ask you, this diabetes, it'll go away, right? Or my blood pressure, it's going to normalize. Like the patient who says, well, I stopped taking that because my blood pressure was great. Well, your blood pressure was great because you're taking your medicine. So That's some of those things are what I do. And this pill planner, you cannot make an excuse for this pill planner. It will not fall apart in a purse. Oh, those fall apart in my purse. No, no. The one I have that I'm able to provide for patients, it's almost suitcase sized. So it's about this big. It'll hold 10 to 15 Metformin 1000, which if you're a pharmacist, you know that that's a gigantic monster pill. It's like the largest vitamin, maybe a calcium supplement pill. It'll hold 10 to 15 of those, and it'll hold at least one of those per day, plus all your other medicines, plus you can even get a pin needle in there if your patient uses an insulin pen. The box has a snap button, so each gate has a button you press to open it. So short of throwing it against the wall 10 or 15 times, it's not falling apart in your purse. It'll pack. So they can't come up with a very good excuse for me. I'm pretty good on that one. So back to who I currently see. In order to simplify the situation, and considering that I'm the only person doing this at my clinic, I do have a little bit of clerical help, but not a lot. I ask the providers to input the ICD-10 code Z91.14. That is a non-billable, non-compliance to medication regime code. So I'm able to run a program and find out each month any person who is seen in any part of the clinic who has that diagnosis code. So I'm able to add them into my list. I also, because it's easy to track in eye care, I don't know how many of you have eye care, but it's easy to track lab tests. So I do anyone who has an A1C greater than 9. I dip down into the 8s because we all know even in the 8s it's not controlled, but this has given me quite a plentiful amount of people to look for. Provider referral. I see pediatric asthma patients for counseling if they're doing their 1-month follow-up with the provider to teach them how to use their inhalers. Also, the providers will ask me to meet with patients who might have specific social or maybe even educational challenges. So I'm talking to those patients who might need one new thing to look at until the next appointment, or might need just 2 new processes for the next appointment. I also have personal referral. If I meet with a patient because they've had more than 8 medications and I feel like this patient probably doesn't really get it, like the little lady who I thought I give a pill planner, this is going to be magic. She comes back the next appointment, I talk to her. Yeah, you know, those don't all fit in there. I said, they do. I've tried it myself. Well, no. I said, well, when do you fill your planner? Well, when I got home with my bottle, I poured them all in there. She had poured the entire bottle and tried to fit it. They don't fit in just one. Okay. So you and I need to have a little bit more of a talk. So currently, out of all that, I have 700 plus, it's actually up to about 730 now, patients that I keep on a list who I actively look for appointments to see. So I know that there are lots more out there, and I'm slowly gathering them, but finding a way to gather them. I tried to add blood pressure as a way to look and see who should I add to this. When I did the eye care report that gave you blood pressure. Anybody with blood pressure of 140/90, 1 week I had 85 patients that popped up. So I was like, that might not be as manageable for just the one person right now. So I increased it up to 150/100, and that was, I think, 20 patients who were seen in a 1-week period. And that's not surprising to a lot of people. That's a little more manageable. So when I get back, I'm going to get started on adding those patients in also. So the benefits, I think they're endless. You increase patient knowledge, you increase compliance, which decreases costs, which may or may not decrease pill burden, which makes patients happy, increases patient morale if they don't have as many medicines. Not only that, but I remind them, do you remember when you were taking your medicine? Didn't you feel better? Then they're like, well, yeah, I did feel better. So hopefully I'm doing all of that. It increases the efficiency of each provider appointment. They don't have to ask specific questions about every single medication on the med list because I've done that, and I've reported to them exactly what the patient told me. So if they have further questions other than what I relay to them, then they can focus on that, or they can focus on just the healthcare side of it, not just the medication side of it. Also, decreases procedural gaps. If I am explaining the process to them and the dietitian is explaining the process, somewhere in there, somebody's going to get that information into their brain. So in the bonus, the thing we all want, better outcomes. I feel like this program really could cause better outcomes. I do think that this program is reproducible. That's the key. I didn't for a long time. I thought, oh, no, this is just my own individual program I'm doing inside my clinic. But now I can see that each care team could have one pharmacist, and we would completely fill their time up. It would be a 40-hour-a-week job for one person for each care team. Going forward, I want to see more patients per day, continue to refine the process so that I'm able to get more patients in, get some clerical help so that I can do that. I can have them do the running for me and the legwork. I'd also like to see if I can't add a COPD and asthma management program in the clinic. Haven't gotten that really up and going yet. Since I'm mostly focusing on diabetes and compliance issues, haven't added that in completely. Like I said, I do meet with patients and talk about their inhalers, but that's a little not as prominent as the diabetes and compliance. So, like I said, one pharmacist for each medical team. So, and that's it. And I hope I spoke in complete sentences. Any questions?
So I have one.
Okay.
And my question is related to how did you get the leadership of your clinic to go along with this program?
First I started small. So I didn't even step out of the pharmacy for part of it. I asked the medical director, hey, do you mind if I pop in if a patient shows up and just kind of talk to them about their compliance? And he said, great, that sounds great. I would love for you to do that. So I was able to see maybe 1 or 2 days a week. I would search for patients I could see. Then I made it to where I was doing 2 days a week completely. So they got a part-time pharmacist to take my position because the medical director saw the benefit. I also threw in there that this was back in the time when we were all trying to say, oh my gosh, how do we meet meaningful use? I also said, who should do reconciliation? I will meet meaningful use. Of course, then it was easier than just having somebody be there. But anyway, so I tried that tack on it. I also just, it was presented to the board just as, hey, this pharmacist wants to meet with patients. And I met with a couple of patients and I had some good reviews. After that, the pharmacy director continued to talk to administration. I don't know what was happening in the background. I know that I was just trying to help whoever I could, whenever I could. And I think that caught the attention of the CEO, and she mentioned it to the board, and the board seemed to like it. So that's kind of how it went on. And finally got another full-time pharmacist to take my spot in the pharmacy. Yeah, I was doing anything. I was, doing special projects on the side. I was, filling prescriptions and counting them, and then running over and checking compliance for a patient. And finally, I just said, you know what? I'm not doing either job the way I want to. And so I was lucky enough to get to do this.
Thank you. Does anybody else have any questions?
Great job on your presentation, by the way.
Thank you so much.
Your pill organizers, as far as getting them implemented and handing them out to your patients and education, how did you do that?
Well, I asked for them. Really. I talked with the medical director and I said, hey, it would really be helpful if I could get some pill planners. And so initially they gave me some really small one daily dose planners. And I said, these are not really working. So I kind of said, hey, and see, in the background of this, like when I finally got a private space, I was in the pharmacy counseling room for a little while. And then, of course, that became problematic because you need to actually counsel patients on other things too. And so I borrowed at the, I would do things like use a printer that wasn't in use. So I was costing almost no money except for my salary. So then I just asked, I said, hey, I need to try to get this. Is there any way that we can get it? We tried to get a grant for the program. That didn't pan out. The particular grant that we were going for had already come to our clinic one time, and they liked to go a different direction the next time. And I just looked it up on Amazon Smile, and I said, hey, this one looks like the one I need. It's going to be big enough. And they said, okay. I'm 100% sure there are grants out there somewhere. I didn't do that kind of research because once I asked, we have a grant department, and they work on that occasionally. And they just said, sure. So I order them as I need them. I pass them out only to my patients.
Sorry if
awesome.
that's not very helpful.
No, that's fine. That's exactly what I was wondering. And how often, like, how many are you passing out a week right now?
Well, it's decreased because I'm currently at a point where I'm seeing I don't have a tremendous amount of new patients to myself. A lot of them are repeat patients. That's another thing I get to do is I follow up with them. So if they have any specific questions, I'm seeing patients 2 to 3 times a year, and so if originally almost every single patient I saw was getting a pill planner. So I was ordering. Well, I'll order 30 at a time, and that might take 2 weeks to get rid of, you know. But now I'm not passing out near as many, just because they already have them. And of course, I'm asking them, you know, how's your planner doing? Is it falling apart? Nope, it's doing good. Only one patient tried to tell me that everything wouldn't fit, and she needed another one, so she could have 2. And I said, I think that maybe. She said, that's okay. I'll just get a separate one. I said, I think okay, let's do that. So that, yeah.
Well, great
That's
job.
about. Thank you.
It seems like it really helped your patients. So
I hope so. That's the whole point, right?
yeah.
Mm-hmm.
Our chief pharmacist and our director of public health nurse are doing a PDSA on a couple of patients at home using one that locks, a med planner that locks and has an alarm.
Oh, yeah.
Have you seen a need for anything like that?
Not yet. I didn't want to push things that far. I was getting a lot of what I wanted, and so I didn't. One additional thing that we did, which kind of goes in the line of what you're talking about, is we did have a patient whose diabetes has gotten so bad she can't see hardly, even with the most magnified. So we were working on trying to get speaking pill bottles or pill labels that had a QSR code on them. I don't know about the locking mechanism ones. I haven't seen any prices on those. When we tried to find out about the people who have the low vision, we were working towards low vision. Even our optometrist said, I have probably 11 people in mind, so it wasn't enough to kind of get a pilot program going. But I can tell that there's a need for that type of thing, but I haven't pushed that far.
Well, our chief pharmacist took it home over the one weekend just to test it.
Mm-hmm.
She put M&Ms in it, and every time it would go off, her kids would want those M&Ms. They got conditioned to knowing what time that thing was going to go
Right.
off.
Well,
So it
and-
worked for them.
Yeah. Well, what I do with a patient specifically is because I generally feel like they're not going to forget to eat unless they're, you know, in a population that does not have access to food very well, which is some of our patients. So one of the things I'm telling with the planner is touch it each time you eat. Start to force yourself on purpose to touch this planner each and every time that you eat. Snack, meal, whatever. I've even got to the point where I've had patients, listen, if you take a drink of water, stop. Don't let yourself have a drink. Go touch the planner with your hands. Don't think about it. Don't look at it. Touch it with your fingers to check to see if you've taken your medicines. Also advise patients there are lots of apps that have pill reminders on them. One of them in particular, and I want to say it's called CareZone. It's so easy to get your med list in the app. You take a picture of the bottle and it loads the label into the app. So you can constantly update that very easily. It's not a typed out thing, kind of like on the Apple, they have the health button where you can add your medications. You got to type those in and change anything. This CareZone app, you take the picture, it loads it, it lets you set up any kind of reminder you want. And then, of course, once I've got to that and we're talking to people about that, they're like, well, yeah, but I've got all these things popping up on my phone all the time. So I'm like, well, at least you have a med list. That's one of the things I forgot to do, too, is when a patient will say things like, I advise every patient to get an updated med list every time they're seeing their provider. So anytime they come into the clinic, they can go to the pharmacy and ask for a 30-day med list, and that should cover, because we only dispense 30 days, that should cover everything. And so that way, they're getting home. I try to be a little low-techy, low-tech about everything. Get it home, they have this list, they go, okay, I got it. They can go down the list and make sure they have all the bottles right before they put them away in the cabinet. So that's one of the things I'm doing. The alarm sounds like a good idea, but I think that a lot of our patients would just think that dinging was in their head. It's unfortunate, but it's true. They might just think, what in the world? Maybe they can't hear very well. So I haven't gone that far yet.
Does anybody else have a question? All right. If not, thank you very much, Dr. Leith, for
Yeah.
your presentation
This
today.
is actually all of my contact information, if anybody wants to contact me, including if anybody has any really good ideas about how I can gather more information easily from the EHR or RPMS or iCare or any of those things. So please take it down. My business cards are safely tucked away in my desk. Thank you.
Well, I hope that everyone is enjoying your lunch and continue to do so, and please continue your conversations. But we are going to continue with our next speaker. Her name is Wendy Williams. She is a native of Chicago, Illinois. She earned her BSN in 1988 from Dillard University in New Orleans, Louisiana, and has since earned 2 master's degrees from the University of Oklahoma. She earned her master's in public health in 1995 and a master's in nursing education in 2008. Mrs. Williams' nursing career has varied in that she has worked for the University of Chicago Hospital, Doctors Hospital, the Tulsa Health Department, Tulsa Public Schools, the Veterans Administration, Tulsa Technology Center, where she was voted Teacher of the Year in 2009, Langston University School of Nursing, and Morton Comprehensive Health Services Incorporated. Currently, Mrs. Williams is the co-owner of Health and Safety Education Consultants, A New Direction, LLC, where she and her partner offer healthcare training for certified nurse aides, certified medication aid, and AHA CPR courses. Mrs. Williams is often seen volunteering and providing health information at church and community functions, which led her in 2010 to found and become the president of the Eastern Oklahoma Black Nurses Association, Incorporated. She is the recipient of the Delta Sigma Theta Sigma Sorority Incorporated Frankie Muse Freeman Community Service Award, presented during the Centennial National Convention in 2013. As well, she is the co-author in an article published in the Journal of Cultural Diversity. Personally, Mrs. Williams has been married to attorney Danny C. Williams for 28 years, and they have 2 children, Morgan, 26, who's a graduate of Langston Tulsa University, and Danny Jr., 22, who's a student at Tulsa University. With all that she has accomplished, Mrs. Williams has found a way to blend her passion, people, with her goal of building a healthier community. She says that her most proud of moments for volunteering with the PTES program is hearing people talk about what they learned from the event. I have heard stories from participants stating PTES helped me respond to when my husband had a stroke. I used what I learned at the brunch, and it saved his life. I enjoy people anticipating when the next event will occur. They often see me and immediately ask, are they going to have the stroke event this year? And finally, I absolutely love sharing my nursing talent at the event through volunteering and encouraging other nurses to volunteer. We all love it. Please join me in welcoming Mrs. Wendy Williams. You can use that, or you can use the button on the machine.
Good afternoon, and thank you for that warm welcome. Thank you to American Heart Association and the American Indian Medical Association for allowing me to stand before you to give you information on the overview of American Heart Association's blood pressure program and resources. This is a group effort with American Medical Association and American Heart Association to improve the health of those who are suffering from hypertension and other cardiovascular diseases. So with that, I won't be before you long, so we'll just go ahead and get started. So in 2017, high blood pressure guidelines, new thresholds, new guidelines, clinical care had come on board, and so this is what we're going to talk about today. Target BP is a joint initiative with American Medical Association. That's with American Heart. The check, change, and control is bridging people and communities in partnership to control blood pressure through self-monitoring, and then the blood pressure kiosk, which is going to help increase engagement and awareness of our health community. So, the new guidelines for blood pressure. I know for me, when this hit, or when this came across the screen on the early morning news, I was like, whoa, that is going to be huge. It definitely impacted myself. It impacted my husband, and it impacted a lot of people that I know. So me being the healthcare provider and educator that I am in the community and at church, I kind of was running, kind of hide behind. I didn't want to answer a lot of questions. I didn't really understand what, exactly what it meant. I had my negative reservations, when I first saw it. And so, but I'm embracing it the more I'm learning about it, and the more that I'm understanding what it's all about, so that I could share the information with others in my community for living a healthier lifestyle. So what the new guidelines are saying is what's normal is a blood pressure on the systolic is less than 120, and on the diastolic less than 180. So most of you all out there are healthcare providers, and you know that on a daily basis, this is probably not what you see in your community. Elevated is 120 to 129, and less than 80. So now, high blood pressure, meaning hypertension stage 1, meaning not pre-hypertensive, but you are hypertensive if you have a blood pressure of 130 to 139 on the systolic, and 80 to 89. And so that's huge. That's huge for me, because now I'm different. I have a label now. High blood pressure for hypertension stage 2 is anything 140 and higher on a systolic, and 90 or higher. And then hypertensive crisis is 180 above and higher than 120. So that is a lot. It's a big change. So we all know the definition of hypertension, and the previous definition would have been blood pressure reading of 140 over 90 or higher. So, and now the revised reading is 130 over 80 and higher, millimeters of mercury and higher. So that means nearly half of all Americans, 46%, have high blood pressure, or fall within this high blood pressure range. So updated treatment recommendation includes lifestyle changes and BP-lowering medication, with a focus on the importance of considering accurate measurements, overall cardiovascular risk, and self-monitoring. So when I started looking at it and talking to my peers and people at American Heart, this part is where I could say, okay, this is manageable. This is something I can relate to, because I'm not one to try to focus on the numbers all the time in my community, because it just sends up a red flag, because we are always the worst, we always have this, we always have that. And so when I said when I started the program, it's going to focus more on, or focused additionally on, lifestyle changes, that was user-friendly for me, because we all know that the numbers may have changed as far as what is considered normal or not normal, but what hasn't changed is the risk factors. And so that's where I get my my energy from, in helping others to understand what this means and what you can do to make a difference for your own health. So the Target BP program has some key facts, and they are that American Heart and the American Medical Association developed and piloted the Target BP in 2015 to improve blood pressure control. They are devoted to building a healthier nation, and this national initiative aims to reduce the number of Americans who have heart attacks and strokes. And so every year I participate in the Power to End Stroke event with American Heart Association, and what people don't realize, and a lot of people, and you'll be surprised, I know it's no surprise to you, but a lot of people in the community don't understand the connection between high blood pressure and stroke. And so we know that high blood pressure is considered a silent killer, so they feel good, but when they have this crisis, this episode and actually experience a stroke, that's when they learn that this is something that could have been prevented if you had control over your blood pressure, for the most part. So, so the goal of the Target BP is to help reduce heart attacks and strokes by urging medical practices, health service organizations, and patients to prioritize blood pressure control. So this is not a program that is putting all of the weight on the physician, but it's actually is asking or promoting that we do a team effort in tackling the issue of high blood pressure. So given the current urgency, Target BP raises awareness and provides additional tools and resources for physicians and their care teams to help patients they treat. Target BP can also help optimize the limited time physicians have with patients to get patients healthier sooner. In addition, our recognition program offers additional practice building and recognition incentive. So I was talking to the staff of American Heart Association on how do we get physicians to really want to be interested in the Target BP program, because when you read it and when I'm speaking to you and just looking at this slide, it kind of says, what do I have to do to be a part of the program? And we all know that in our offices and our hospitals and practices, we have tons and tons of things to do already as it relates to taking care of our patient population. So does Target BP add an extra piece for me to do? American Heart is hoping that this will not be seen as something extra that you have to do, but something that is going to actually enhance your practice and improve your patient outcomes. So Target BP Improvement Program, the M is for measure your blood pressure accurately every time. So proper measurement is critical to controlling blood pressure. Build a protocol to ensure accuracy of blood pressure readings. And we all know that people who are diagnosed with hypertension, for the most part, have some type of device at home that they monitor their blood pressure with. At least we hope they do. There's also other places and other ways they can get their blood pressure, but to accurately, every time, measure their blood pressure is huge. It's a huge learning curve for our communities for if they're going to be self-monitoring. So this program is going to help emphasize how important that accuracy is every time. The A is for act rapidly to address high blood pressure readings. This step requires rapid action during a patient visit and prioritizes follow-up appointments and a clear treatment plan to help patients achieve blood pressure control. The acting rapidly and follow-up that I know, if I'm thinking about my own experiences, I'm supposed to go to the doctor every 3 months to have my blood pressure checked, and I'm a pretty compliant patient, so that will work for me. But many of our patients in the community, in our practices, that 3-month time frame might be an opportunity to lose a patient. So This is going to be huge on how are we going to act rapidly and keeping the patients engaged. Do we need to bring them back monthly, or is every 3 months going to work? So that's something to think about. That's something I was thinking about when in reading the guidelines in the program. And P is for partner with the patient, family, communities to promote self-management. Real change comes from when patients take ownership of their health. Engage with patients, their families, and communities help promote sustainable lifestyle changes, thus supporting the improvement in overall health. So this part of the program, again, was exciting for me because it's the opportunity that we wrap our arms, or we use an interdisciplinary approach to helping the patient manage. So it's just not about getting your blood pressure checked, getting a medication and being sent home and then coming back for your blood pressure reading. But the hope is that we get people connected to dietitians to help with nutritional planning and eating better, helping them with those weight issues that they may have, to help with lowering their blood pressure. So Target BP is to be set up in our practices in hospitals, but I don't think it's meant to be used alone, that we are going to have to use a team approach in order for it to be effective. User-friendly learning and discovery, the Target BP patient resources. Now, in the world of technology, and as much as it is in our society, some people still are a little shy with technology. Some people aren't as great with it, but for the most part, everybody is getting on the computer or using some type of technology. So with the program, they are offering patients to seek additional information about high blood pressure so that they can learn and have open conversations with their physician. That would be huge if your patients could come in and actually have questions and actually have dialogue with you and show you that they are actually engaged in their health and doing something as it relates to lowering their blood pressure. So this website, loweryourhbp.org, is a website that has valuable tools and resources that the patient can download, print off, and actually bring to your practice and ask questions and give you an opportunity to feel like you are really making a difference in your patient's care. So, evidence-based high blood pressure measurement program that uses a tracker to empower patients to take ownership of their cardiovascular health. So check for high blood pressure and symptoms, then change lifestyles and seek treatment, and then control hypertension by taking preventative measures. So the Target BP program is all about the 3 C's: check, change, and control. The average drop in blood pressure over the years from 2012 to 2017, you can see on the screen there. The overall average pilot year to present is 11.47 millimeters of mercury and on a systolic, and 7.89 on a diastolic. That's a big number, and that's a good number. My husband needs to drop about that much, and so if this is the goal and this is what we're seeing, from my perspective, it looks like that it probably works. So you can make your own assumptions. So easy to use tracking tools for participants and volunteers. There is an administrative site as well with real-time reporting on participant enrollment and blood pressure improvement. There is a unique campaign code that can be created to each site to use for your enrolling participants. So that means that you'll have a code, and when your patients enroll, you will actually get to see and track them on that. So heart.org/CCC. So the BP kiosk sponsorship, the key facts include leverages the groundswell of awareness as a result of blood pressure guidelines. This opportunity is designed to work with community sponsors to promote self-monitoring and check change control program. 2, 1, increase awareness of connection between high blood pressure and the risk of heart attack and stroke. It is to drive innovative approaches in healthcare systems for blood pressure management, and then to increase high blood pressure diagnosis among those at risk. And finally, increase the number of Americans controlling their high blood pressure. So why is Target BP like everything else American Heart Association does? Life is why, and you can kind of put that name in there or that experience to kind of personalize it, why it's important to you. Any questions? Are all of you physicians or nurses or healthcare providers or at some level for the most part? Cool. All right. Well, good luck.
Let's give another round of applause for Mrs. Williams. So, what I'd like to do before we close today is to show you a few resources that I came across in my work with our Million Hearts funding, as well as other resources that have kind of come across my path in recent years. And one of those, to start with, is I'm going to show a couple of videos that the Montana Cardiovascular Health Program developed. They have a series of these videos. The first one that I'm going to show is in the Salish language. So they worked with a contractor to develop some self-monitoring blood pressure videos in native languages in Montana. So the videos, a couple of them that you'll see today, are within their first round, and then they have some additional videos that will be coming out.
Kam spes kitapan kita kaisena satu. Kam spes kitapan kita kaisena satu. Mata kutuka pi kuskitsippi. Ke kutukis. Ke kimataksi kamishpa. Kam spes kitapan itapsuka pi kakitaisena satu sanni kukua. Kidaksitsipsata kitasukinaki. Kidakitkuskini panne. Makanistum pianne utaki kidakuhtanistihpi. Ni tui kanaeksistikoi kidakitassa tsipanne kitsapan kampspis. Oke kimataksimspa, kimataksuispa, kimataksimspa äsiksikimi. Kitakayuhkima ni puskinitaksin kilakatsituutsip kitsapan. Kitakin spupi, kene kuutsis kitakituhkituhtuupani taasuyo, hakanisspiani kituskitseppi. Kene teaksa tsipani kitsaapani, kene kitakituutaktuupani, ki muhkinstis, kitaksuka puhtuup, hani utsisutsitsishpi. Kitaksuka puhtuupani, kamattayaa pianistuomia tuup, Takaisinnissianne kuutsis itapstianne kuutsisan. Kilahutsita stakinatu kami kukitsiksi kilakitu tuhtuupianni tässä kitsaapani kenne kuutsis. Kenniki suupaats kitakitsukupihan. Ens pupit kidatsikistunu tuonaasaa piikkinamaatsis. Aki tomatapa pinik akuhtaissineemia manistih kitsaapani ke kristaapis kitakitessaatsi. Nihki sinakaasi kamsei sukaapis Kidakatsit tupi, matsisituiskinetaksin, kidakatsit saatsi. Kidaksinep, kitsapane manistihpi, ke utsituutsipi, ki manistuunspi. Kidaksitsipsata kitasukinakim. Kidakatsituutsipurtu pinihkihtassaatip kitsapane. Kidakitanista kidaisukapiikanistassaatip. Kamessaatsim kamspis kitsapane. Keni kidakitassaatip pannikiukua. Itapsukapi kaksukapis kitsapane.
I think sometimes when we think about approaching high blood pressure, oftentimes the easiest thing is sometimes overlooked. And so what I found in my work is that sometimes if you make things that look like the communities in which you serve, that people can identify with those in a much better way. We had a diabetes program where we took some materials, swapped out the pictures, used some wording that was familiar with the community, and just to raise more awareness around diabetes. So some of those same things can be taken when you're looking at resources and materials for addressing hypertension. But another resource that I wanted to highlight today for you is this hypertension control change package for clinicians. So there are some hard copies outside on the table. You may have picked one up already. But our Million Hearts funding really focused around this change package. I will be honest and tell you that it is very wordy if you haven't already looked through it. But it does have some really good steps in it. Very simple things that you can do where you work, such as identifying a champion for your efforts. It can be something as simple as working on goal setting with your patients. Or you could look at making sure that everybody is taking blood pressure in the same way. So this just provides a menu of options of things that maybe you're doing, but maybe you could supplement with another strategy to help boost your efforts. And then last but not least, AAIP has its own Million Hearts page. If you go to the top of our website and you look under our programs, so it has some, and you go to capacity building assistance programs, you'll find Million Hearts there. But this page talks a little bit about what we did with the Urban Intertribal Center of Texas, who spoke this morning, and also the Hunter Health Center in Wichita, Kansas. And then down below, you have these resources that are available for the clinicians. So if you get to the Million Hearts site and you're like, I can't find that thing that she showed us, feel free to come here. It'll definitely be an easier way for navigating some of those resources. And with that, I would like to thank everybody for coming today, for sharing the information about what you're doing in your respective areas. I definitely hope that you take away some valuable information as you think about addressing hypertension where you work. And feel free to share any additional resources or information with me. One of the things that I try to do as being at events like this, I uncover new gems to share with our providers, as we are a physicians membership organization. So if there's anything that you're doing and that you'd like to share with our providers or with our network, please let me know, and I'll be happy to make sure that that information gets disseminated. So with that, I will thank you once more for being here, and you are free to go home.